Good morning. My name is James Valentine, and welcome to the externally led, patient-focused drug development meeting on cardiac late effects in pediatric cancer survivors. I'm here in the studio with my co-host, Steve Wasala from Children's Cancer Cause, and we're coming to you live from the Washington, D.C. metropolitan area, actually not too far from where the U.S. Food and Drug Administration's headquarters are located. It's my pleasure to introduce Steve, who will be providing some opening remarks for today's meeting.
And thank you, James, and welcome everyone to today's externally led patient-focused drug development meeting on cardiac late effects in pediatric cancer survivors. The mission of Children's Cancer Cause is a long, healthy life for every child with cancer. We're working to help develop better and less toxic treatments and to advocate for better policies and programs that will address the multitude of needs faced by more than 500,000 survivors who face a lifetime of health challenges due to the toxicity of the treatment they received. While helping to prolong life, too often drugs, radiation, and other treatments take a toll on survivors who grow into adulthood and face risks for a plethora of late effects, including hearing loss, osteoporosis, and fertility issues, among others. One of the most severe is the impact on heart health. As many of the drugs we use today were developed 40 to 50 years ago, it's clear that we need less toxic and more effective solutions to treat childhood cancers. We also urgently and desperately need better treatments for people living with cardiomyopathy and other cardiac late effects. Our work has put us into contact with many patients and caregivers whose powerful stories you'll hear today. We hope and expect this meeting will impact the way we think about this population's needs, encourage future research, and successful new product development for people living with these late effects, people who urgently need more options to maintain or improve their health. While listening and learning today, I ask all of the regulators tuned in, researchers, clinicians, policymakers, and those who develop new drugs to listen to the stories and the needs that better, more effective drugs could address. I want to thank the U.S. Food and Drug Administration for giving us permission to hold this meeting and for attending. We're incredibly grateful to have this opportunity to share our experiences with you. Today we're hosting this meeting in conjunction with our partners, the American Society of Clinical Oncologists, the American Society of Pediatric Hematology Oncology, the American Academy of Pediatrics, Teen Cancer America, and the Andrew McDonough B Positive Foundation. Thank you also to our generous supporters who have financially sponsored this meeting, including Day One Pharmaceuticals, Whole Foods, Community Health Charities, and the Stewart Initiative for Childhood Cancer Survivors, a program of Children's Cancer Cause. In addition to many survivors and caregivers, we're really pleased to have in attendance representatives from advocacy and professional organizations, clinicians, drug companies, federal agencies, and universities from across the world. And to the people and families affected by cancer and your loved ones participating, this meeting is really for you. We invite you to call in or write in during the program and ask that you participate in the remote polling as well. We want to hear as many perspectives as possible, and please know that we will do our best to get to all your comments. Please, when you respond, only use your first name. No other identifying information should be shared. The comments that we cannot get to will be just as important because they will be collected and published in the forthcoming Voice of the Patient report, which is a comprehensive summary of today. So let's get started. And to begin today's meeting, I'm thrilled to introduce Dr. Gregory Riemann. Dr. Riemann is the Associate Director for Pediatric Oncology at the FDA's Oncology Center of Excellence in the Office of the Commissioner. He's also the Associate Director for Pediatrics, Office of Oncologic Diseases, and the Center for Drug Evaluation and Research. He's been a leader in research and patient care in the pediatric community for many years. Dr. Riemann, welcome to the program.
Thanks for that introduction, Steve. I very much appreciate the invitation to participate in today's externally led, patient-focused drug development meeting on reducing cardiotoxicity risk in childhood cancer survivors. On behalf of the FDA's Oncology Center of Excellence and the Office of Oncologic Diseases, I'd like to welcome all the participants to this virtual meeting. And I'd like to commend the Children's Cancer Cause for initiating and for planning and the organization for today's event. Just one more manifestation of their longstanding interest in and commitment to assuring optimal patterns of care to improve quality of life of childhood cancer patients and survivors. I especially, however, want to commend all of you participating survivors and your families, as well as those parents who've experienced the heartache of losing a child to the cardiotoxic effects of cancer therapy, for your willingness to share your personal experiences. I really want to assure you that your real life description of the impact of cardiotoxic effects of successful cancer therapy on your own lives and on the lives of your children will have a meaningful effect on the development of less cardiotoxic but equally effective cancer drugs and on the investigation and development of effective cardioprotectants, and on the pediatric development of existing and new drugs to manage cardiac dysfunction caused by current cancer therapies. The excitement for the medical history making progress in improving the outcomes of children with cancer, changing a once uniformly fatal disease to one in which the majority of children experience prolonged event-free survival and cure is unfortunately dampened by our realization of the burden and the cost of treatment experienced by patients and families. I'm not talking about financial costs, I'm talking about costs in quality of life and quality of survivorship. A growing number of childhood cancer survivors experiencing life-altering, if not life-threatening disabilities as side effects of effective therapy. And I would note that cardiotoxicity was one of the earliest and one of the most concerning, and it remains so. It has really transformed pediatric cancer clinical research so that in the strategy for designing new clinical trials, a focus on safety, especially long-term safety, is as important as evaluating effectiveness. Whereas there's been some progress in the diminution of long-term persistent and late toxicities with the use of risk-adjusted therapies, the reduction in dose or fields of external beam radiotherapy, we still recognize that there is a need to identify other potential predictors of cardiac adverse events associated with chemotherapy, most notably anthracyclines. The 10-fold increase in stroke and coronary arteries disease and the 15-fold increase in heart failure experienced by childhood cancer survivors compared to their normal siblings are not statistics that can be adequately addressed by the use of the only available cardioprotectant, dexrazoxane, which is used widely in the standard of care for children receiving anthracycline treatment, but it remains unapproved actually for the use in the pediatric population. The risk of cardiotoxicity is from cancer treatment, particularly that related to anthracyclines, certainly not restricted to children, something that we have known about since their early introduction into cancer therapy in the early and mid-1970s. And we have now recognized that age at the time of exposure and lifetime cumulative dose remain major predictors of potential risk. And you'll hear today from two very notable experts in cancer survivorship and cardiac toxicity on new approaches to identify the underlying biology of cardiotoxicity and potential risk factors. This unique opportunity provided by these externally led patient-focused drug development meetings, in addition to the fact that they are externally led, is that all stakeholders can learn from the personal experiences that each of you and only you can provide. you survivors, families of survivors, families of children who unfortunately did not survive and succumbed to the cardiotoxic effects of chemotherapy. Clinical investigators and basic scientists alike can be informed by your real-life experiences when developing strategies for preclinical and clinical investigations, as can the pharmaceutical industry, both large companies as well as small emerging biotech companies involved in the pursuit of developing active anti-cancer agents with less cardiotoxic adverse event risks. And they may provide opportunities for reducing lifetime complications of myocardial damage caused by cancer therapy. As the drug development cycle begins with discovery, sharing your individual experiences again has an impact on academic investigators and industry. And just as an example, we had the opportunity several months ago in our research rounds in the Oncology Center of Excellence to hear the results of a small company in Northern California, a commercial spinoff from Stanford University, was committed to developing a small molecule cardioprotectant who shared their promising but very early preclinical data in animal models that they plan to use to support clinical testing in humans. We would expect also that our colleagues in the Division of Cardiology and Nephrology may also be informed by your shared experiences in decision-making related to the use of approved or investigational agents in treating symptomatic cardiac disease or preemptive use of such agents to delay or mitigate adverse cardiac events. The review of early clinical trials of new investigational drugs, as well as a review of new drug applications by the FDA, are designed to evaluate the meaningful clinical benefit provided by a new drug in the context of a benefit risk assessment of that new drug. And while analysis of quantitative safety or toxicity data available from clinical trials is obviously critical to such decision-making, the qualitative reporting of real-life patient experiences provides important additional context. As our understanding of meaningful clinical benefit can be summarized by how a new drug affects how a patient survives, feels, or functions, today we have a very unique opportunity to hear from you survivors, how you feel and function, and from families who unfortunately lost children as a result of adverse cardiac effects from successful cancer therapy. I can assure you that we are here to listen and to learn. You all have much to teach, and I hope that this meeting has ultimately the impact that you deserve and that is expected by the Children's Cancer Cause. Thanks very much for the opportunity to meet with you today. And back to the studio.
Thank you so much, Dr. Riemann. And now I would like to introduce Dr. Smita Bhatia, who will be presenting a clinical overview of cardiotoxicity in cancer survivors to help create a scientific foundation for the rest of today's meeting. Dr. Bhatia is the Director, Institute for Cancer Outcomes and Survivorship in the School of Medicine at the University of Alabama at Birmingham. Dr. Bhatia established the Institute for Cancer Outcomes and Survivorship at UAB, and she is an intentionally renowned leader in cancer survivorship and outcomes research. Dr. Bhatia, take it away.
Hello, I'm Smita Bhatia. First of all, I want to thank you all for a very kind introduction and for this invitation to present here. I am from the University of Alabama at Birmingham, a pediatric oncologist, and I direct the Institute for Cancer Outcomes and Survivorship. Today, I will be talking about the etiology and pathogenesis of cardiomyopathy, especially in the setting of anthracycline exposures in cancer patients. Cardiomyopathy in cancer survivors is anthracycline-driven. Modifying factors include chest radiation, younger age at exposure, female sex, and then cardiovascular risk factors, which include diabetes, hypertension, dyslipidemia. There's a very strong dose-response relation between anthracyclines and the risk of cardiomyopathy. Here we show you a slide in which the x-axis has the dose of cumulative anthracycline exposure, and the y-axis is the risk of cardiomyopathy. So just to interpret this correctly, those who received less than 100 milligrams per meter squared of anthracyclines are at a 1.6-fold higher risk as compared to those who received no anthracyclines. Those who received 300 plus milligrams per meter squared of anthracyclines are at a 28-fold higher risk as compared to those who didn't receive any anthracyclines. Another important point to note is that about 200 to 250 milligrams per meter squared is when the risk starts climbing sharply. About 60% of children exposed to high-dose anthracyclines demonstrate echocardiographic indices of abnormal cardiac remodeling. When we look at anthracycline-related heart cardiomyopathy, we can see the following things happening in the heart. First, there is these individual cell dropouts. You see these white holes there. This then leads to necrosis in the heart. These pink areas, these are the necrosed heart muscle. This then leads to fibrosis. It's initially patchy, but all over the place with disruption of the structure of the heart. And then it progresses into more scarring or interstitial fibrosis, and finally leads to a dilated heart, which is the cardiomyopathy and heart failure. But there's significant inter-individual variability in the risk of anthracycline-related cardiomyopathy. And when I mean that, I want to show you here how that happens. These are childhood cancer survivors who developed cardiomyopathy. Each green dot represents a case, and it's lined up against the dose of anthracyclines. So when you cut the dose at 250 milligrams per meter squared, you see that there's a significant number of individuals who developed cardiomyopathy at the lower dose. On the other hand, if you look at controls, which are childhood cancer survivors who did not develop cardiomyopathy, and cut the dose again at 250 milligrams per meter squared, you find that there are several individuals who received higher doses of anthracyclines but escaped the development of cardiomyopathy. This then begs the question, is there a role for genetics playing here in who develops cardiomyopathy and who doesn't? So with this in mind, we developed a framework where we said, when you get high doses of anthracycline, remember higher doses increase the risk of cardiomyopathy. They have to first cross the cell membrane. And sometimes in some individuals, there is more efficient crossing, and in others, it's less efficient crossing, again, often dependent on what kinds of genes you have. This then leads to two ways in which the anthracyclines are metabolized. One is this, the other one is this, which then leads to direct insult to the heart muscle. On the other hand, there could also be problems with the way iron is handled in the heart, and then this leads to what's called increased reactive oxygen species, which cause oxidative stress, meaning they hurt the heart muscle significantly by causing the mitochondria to not behave, leading to the heart to again develop those small cell dropouts, and then leading to progressing to scarring of the heart muscle and then heart failure. So we studied this in our group, and we had 170 childhood cancer patients who developed cardiomyopathy participate, as well as 317 childhood cancer survivors who didn't have cardiomyopathy. Same age at diagnosis of the primary cancer, younger at the age of diagnosis of amongst the cases as compared to the controls, and about 75% were non-Hispanic whites. This is their primary cancer diagnosis for the cases and controls. We carefully matched them so that that particular element didn't come into play when we were looking at what particular genes were causing heart failure. The anthracycline exposure was higher in the cases, 300 milligrams per meter squared for cases, 140 for controls. Chest radiation exposure was more in the cases as compared to the controls. Now we're looking at a particular gene which is associated with cardiomyopathy. Why did we look at it? Because this particular gene produces an enzyme which then converts this into a particular metabolite of the parent doxorubicin, which is much more cardiotoxic. And it's quite common amongst the white folks. 31% of them have it, Black folks, 51%. And what it also does, it helps us differentiate the people who have the high risk gene are much more likely to develop cardiomyopathy as compared to those who have the low risk gene. And the difference is there at all doses of cardiomyopathy, of anthracycline exposure. Also, we see that this enzyme is produced at much higher levels in the cardiotoxic variant of that particular gene as compared to those who carry the non-risk gene variant. This is where it sits in our whole model that I showed you here. Now we're looking at the role of cardiovascular risk factors. Remember, we discussed earlier that they increase the risk of anthracycline-related heart failure. So here, if you were to take only high-dose anthracyclines, they result in a higher risk of heart failure, 10-fold higher risk as compared to those who didn't receive any anthracyclines. But if you add hypertension to the mix, it increases the risk tremendously. You add diabetes mellitus to the risk, increases the risk even further. And this is where we have to pay attention. And we are becoming increasingly aware that we need to manage the hypertension and diabetes amongst those who had received high-dose anthracyclines carefully in order to prevent heart failure from developing. But for our purposes, we harnessed this information in order to take a particular set of genes which are associated with cardiovascular disease in the general population to see if we could find another gene which was associated with anthracycline-related heart failure. And indeed, we found one. We found this particular gene called HAS3, present in 34% of the individuals, this high-risk variant, such that there are two types of variants which don't really increase that risk so much. But there's a particular variant which tremendously increases the risk, especially at doses which exceed 250 milligrams per meter squared. We replicated these findings in order to be sure that what we'd found was indeed true. And this particular variant results in protection from making this toxic material called the reactive oxygen species, which then has a downward cascade resulting in heart failure. So if you have high amounts of this, it protects you. If you have low amounts of this, it increases the risk of heart failure. We found yet another gene which was associated with cardiomyopathy. Again, there are two types of these genes which really don't result in much of a heart failure, but then one particular gene increases the risk tremendously, particularly around the doses of 250 milligrams per meter squared where it starts increasing. Again, replicated it in another population in order to make sure that we had made a true finding. And this particular gene results in decreased contractility of the heart, which then results in heart failure. There are others who've been working on this and have identified several other genetic variants, many other genes, which I've shown you out here in red. And all of these have been found to be associated with increased risk of heart failure. Really, these are pieces in a puzzle fitting in order to understand why some individuals get heart failure after anthracyclines and others don't. And this was then taken on, and I'll tell you the story here. Have high doses of anthracyclines, you have young age and female sex, there's an increased risk of cardiomyopathy. But genetic predisposition, presence of cardiovascular risk factors, diabetes, hypertension, etc., and sometimes viral infections lead to an increased risk of cardiomyopathy. We can harness all of this in order to identify those who are at the highest risk, so we can upfront modify how much anthracyclines we are using, screen them at a higher frequency with echocardiograms or lower frequency if they're not at increased risk, or use risk reduction protocols that can help us then in targeted groups, only those who are at high risk of developing heart failure, reduce the risk of this particular complication. Can we identify those upfront who are at high risk of heart failure? Yes, I think we can. There was this study conducted by a Canadian group where they took, they created a prediction model where they had clinical factors, including anthracycline dose, as well as several genes, and they put them into a model and they classified patients into 3 risk groups: high risk, intermediate risk, and low risk. And these can then hopefully be used to have a targeted approach in order to reduce the risk of heart failure. I would like to thank my collaborators because indeed it is a team that does all this work. I would like to thank my team at the University of Alabama, Birmingham, as well as the funding agencies and the patients and their families, because without them, these efforts would not be possible. I would like to now go back to the studio. Thank you very much.
Thanks so much, Dr. Riemann and Dr. Bhatia. I'd now like to welcome our moderator for today's meeting, James Valentine, who has been working with us over the past several months in the planning for today's meeting. James has worked the last 14 years as a champion for the patient voice and previously worked at the FDA where he was a patient liaison, helping to incorporate the patient voice into medical product review. There, he helped to develop and launch the Patient-Focused Drug Development Initiative, which this year celebrates its 10th anniversary. In private practice, James has worked with many patient organizations to ensure their community's voices were heard by decision makers. Relevant to today's meeting, James has been involved in helping plan and moderating 3/4 of the over 60 externally led PFDD meetings, including Children's Cancer Causes' previous meeting on chemo-induced hearing loss. So we're in really good hands today with James. James, welcome.
Yeah, well, thank you so much for that introduction, Steve, and so great to be here with this community today to really help understand and learn from all of you. So now that we've heard a clinical overview from a disease expert, we turn to the core of today's meeting, which is to hear from you, people living with or at risk of cardiac late effects due to treatments for their pediatric cancers, and their direct caregivers and family members. Patient-focused drug development, or PFDD, is a more systematic way of gathering patients' perspectives on their condition and on available treatments. As you heard from FDA's Dr. Riemann, your input can help inform the agency's understanding of these cardiac late effects that will help inform drug development and FDA's review. While FDA has held many of its own PFDD meetings, today marks the 62nd externally led PFDD meeting, which is a truly unique and important opportunity for this community. Today's meeting is interactive, so let me tell you a bit about what we'll be asking of you and how today's meeting will be organized. First, we'll be exploring the patient and caregiver experience of living with cardiac late effects and their impacts on your daily life. Then in our afternoon session, we'll build on that, bringing everybody back together to explore the various approaches to treatment for the heart-related issues, including experiences in clinical trials. And we'll also be asking for your preferences for future treatments for cardiac late effects. So what will these two discussions look like? Well, we'll be using a few different methods to hear from as many of you as possible. First, we'll kick off our two sessions by hearing from panels of both patients and caregivers of individuals that either have or are at risk for cardiac late effects. These panel discussions will set a good foundation for our broader discussion, as these individuals were selected to reflect a range of different experiences with cardiac late effects and the various treatment approaches. This will also help facilitate the audience discussion, which is will be brought in to bring all of you in our live audience, both patients and caregivers, into our discussion and to hear your voices. This will build on the panel discussions by reflecting your individual takes on these topics. I'll be asking questions and inviting you to provide a comment. This can be done in one of two ways. We want you to dial in by phone, or you can submit a written comment throughout, and we'll be giving instructions on how to do both of those things a little later in the program. You'll also see that we will welcome a Zoom panel of patients and caregivers who will also be sharing their perspectives during that live discussion. Third and finally, we'll be broadening our understanding of your experiences through use of different polling questions. Patients and caregivers will be able to use their phone or a different tab in their web browser to respond to these questions. And actually, at this point, I'd like to ask that you go ahead and get into the polling system, so that way when we get to our first set of polling questions, you'll already be able to help answer those. And you'll be able to stay on this web page throughout the day. So you can go ahead and pull out your phone, open up a browser, open up a new tab, and go to www.pollev.com/childhood cancer. Again, please feel free to go there now, www.pollev.com/childhood cancer. And this is for our patients and caregivers only, and we'll be getting to these polling questions very soon. These polling questions, this is to help us understand your experiences, but also to help inform the discussion. As you answer various polling questions, we'll want you to think about your responses and help us understand why you made those selections, and hopefully call in and write in to help explain. I also want to note that we'll have an opportunity to provide written comments for 30 days after today's meeting. While we'll be trying to hear from everybody that wants to be heard today, we know that we may not be able to get to all of your comments today, or we know that you may have additional comments that come up as you're reflecting on this meeting tonight or in the coming weeks, or perhaps you're watching this on demand and you want to be able to provide your input too. Your written comments are welcome as well. All of today's input, as well as all of this written input, will be summarized in what's called a Voice of the Patient report, which will be provided to the Food and Drug Administration, as well as be made available publicly for researchers and drug developers. One last thing before we get started, I'd like to go over a few ground rules for today's discussion. We encourage pediatric cancer survivors and their caregivers to contribute to the dialogue, again, through polling, calling in by phone, and submitting written comments. The discussions today are limited to patients, family members, and other direct caregivers only. Other attendees that may be from the FDA, from drug development companies, clinicians, and researchers, they're all here to listen. I also want to mention that views today are inherently personal and that the discussion may get emotional at times. So please, respect for one another is paramount, and to that end, please try to be focused and concise in your comments so we can hear as many voices as possible. So without further ado, let's get into it, and let's go to our first set of polling questions, which is to get a sense of who we have in our audience today. So again, please, if you haven't already, open that tab or open that browser on your phone, open a new tab on your web browser on your computer, go to pollev.com/childhood cancer. We'd like to get everybody, all of our patients and caregivers, into the system so that way you can answer these questions throughout. And as a reminder, once you get to this web page and have this up, you'll be able to stay on this web page throughout the day. Anytime we go to a new polling question, it will automatically appear. So you'll be able to contribute throughout the day. So our first question is, we want to know who we have in our audience. We want to know, are you either a person with a person living with treatment-induced cardiotoxicities? Are you a person that doesn't currently have cardiotoxicities, but is at risk of treatment-induced cardiotoxicities due to your cancer treatment? We also would like to know if you are a caregiver of someone living with treatment-induced cardiotoxicities. And finally, if you're a caregiver of someone that's at risk of treatment-induced cardiotoxicities. So caregiver of someone who is not yet currently experiencing cardiotoxicities. So we'll give everybody a few moments here to get your responses in, just so we know who you are from the start, and we'll be able to track your responses throughout today's meeting. As it stands, it looks like about half of our audience is representing, or are people that are cancer survivors that are living with treatment-induced cardiotoxicities. After that, our next largest group represented are the caregivers of those individuals, individuals living with treatment-induced cardiotoxicities. Although I'm glad to see that we also have representation from those who are at risk of treatment-induced cardiotoxicities, both the patient perspective and the caregiver perspective. Even though you're not yet experiencing these health effects, we do want to hear from you. We want to hear in the morning about your worries for the future, and we want to hear in the afternoon about what your treatment goals would be, perhaps for something to help prevent these potential health effects. So welcome to all. You all are, these are if you picked one of these options, that means we want to hear from you today. If we go to our second polling question, now I'd like to know for our people who are pediatric cancer survivors, for you, or if you're a caregiver for your loved one, what is their current age? So the options are A, 0 to 3 years old, B, 4 to 8 years old, C, 9 to 12 years old, D, 13 to 17 years old, E, 18 to 25 years old, F, 26 to 35, G, 36 to 45, H, 46 to 55, or I, if the person affected, the pediatric cancer survivor, is older than 55. And you'll notice that for the remainder of our polling questions today, we're going to be asking about the person who is the pediatric cancer survivor. So if you're a caregiver, you'll be answering, thinking of that person. And while these early polling questions are more simple in terms of just asking demographics, we'll be asking some more health, quality of life related questions a little later in the program. So as it stands, it looks like we have a good spread, starting with the early teenage years, all the way through those that are older than age 55. The largest two age ranges represented today are those in the 26 to 35 age range or the 36 to 45 age range. We do not have any individuals represented in that 0 to 12 age ranges, which perhaps reflects the fact that those would be individuals that may currently have pediatric cancers, are undergoing treatment, and so would not yet be in that kind of post-treatment phase where you're thinking about post-treatment effects. If we can go to our third polling question. Please stand by as we try to get our third polling question up here for you. Please hold one moment. All right, so here we want to know, where do you and your affected family member currently, reside? The options are A, the Eastern time zone, B, in the U.S. in the Central time zone, C, in the U.S. in the Mountain time zone, D, Pacific time zone, E, Alaska time, F, Hawaii time, G, if in Europe, H, the Middle East, I, Asia, J, Canada, K, Mexico, or L, some other country or region not reflected on this slide. So please let us know where you or your affected family member currently resides. All right. With any final responses that may trickle in, we'll go ahead and we see that our largest contingency is from the Eastern time zone, followed by Central as well, but we do have representation from some of the more westerly time zones, both Mountain, Pacific, and Hawaii time. Hopefully as the day goes on, we'll have more individuals from the West Coast time zones be joining us. We also do have representation from Europe, so this is not, input today is not limited to just those living in the United States. If you're tuned in from outside of the US and you're a pediatric cancer survivor or a caregiver, we want to hear your voices too. We can move to the next polling question. So here we'd like to know, or would like to ask, how would you describe your or your affected family member's gender? The options are A, male, B, female, C, other, or D, if you prefer not to answer. So again, we want to know your or your affected family member's gender. Give you a few moments here to get in responses to this question. Again, just to get a sense of who we have in our audience that will be participating throughout the course of today's meeting. So we'll give you just a few more moments here to get in your responses. It looks like we are shifting a little bit here and there, but it's about 2/3 of our audience, the affected individuals, the pediatric cancer survivors, are female, and about 1/3 of the audience's pediatric cancer survivors are male. No one selecting other or prefer not to answer. So we move to our 5th polling question. So here we want to know, what is the age the age you or your affected family member first received cancer treatment? So this would be the first time of cancer treatment for you as a pediatric cancer survivor, or if you're the caregiver, please answer for your loved one. The options are A, between 0 to 3 years old, B, between 4 to 8 years old, C, between 9 to 12 years old, D, between 13 to 17 years old, E, between 18 to 25 years old, or F, between 26 to 35 years old. And yes, maybe some of those late response options are a little bit generous in saying what is a pediatric cancer, but we do want to, if you're here today, do want to know if you fit into one of those categories. All right, so while any final responses are coming in, we see that our largest cohort today represents those that had their first treatment between 4 to 8 years of age, followed by those that received treatment between 13 and 17 years of age, those teenage years. And then third would be those that are between, our newborn to 3 years old. We do have representation, though, but from those that received their first cancer treatment between the years of 9 and 12, as well as some that had treatment between the years of 18 to 25, and no one selecting years 26 to 35. Of course, recognizing that the focus of today's meeting is on pediatric cancers. And we have one final polling question for this first batch, again, to understand who we have in our audience. We go to our 6th polling question. And so we would like to hear, we just asked you about when you had your first cancer treatment. Now we would like to know the number of years that you or your affected family member have been living with cardiac late effects. The options here are that it's been 1 to 5 years since completing your cancer treatment, B, 6 to 10 years since completing the treatment, C, 11 to 14 years since completing treatment, D, 15 to 25 years since completing treatment, E, 26 to 35 years since completing treatment, or F, if more than 35 years with cardiac effects. G is if you are currently on cancer treatment and you have not had any cardiac late effects. And H, if you have completed your cancer treatment, but you have not experienced cardiac late effects. So in summary, response options A through F are for those of you that have cardiac late effects, to let us know how long it's been since you've completed cancer treatment. And then G and H are if you are not yet experiencing cardiac late effects. So as it stands, with final responses still trickling in, we see that the largest cohort represented today are those that have been between 15 to 25 years since completing cancer treatment, followed by those that are even longer, 26 to 35 years since completing treatment. We do then see kind of a clustering of a few others, both the 11 to 14 years and more than 35 years since having treatment. We also see a fair number of people that have completed their treatment but have not yet experienced late effects. And as I mentioned earlier, we want to hear from you as well about your worries and your treatment goals. And then we do have representation from those that are a little bit closer to having completed cancer treatment, both the 1 to 5 year range and 6 to 10 year range. Nobody today is currently on cancer treatment and not having experienced cardiac late effects. So I want to thank you all so much for completing these polling questions. I promise you that as we go to polling questions later in the day, they'll be a little bit more interesting and actually difficult to answer, helping us understand your experiences and the impacts of cardiac late effects. But at this point, I'd like to move us into our first meeting topic. And I'd like to project our discussion questions for this first topic to give you all a sense of the different questions that we'll be asking you to weigh in on. So in this morning session, we really want to understand what it is to live with cardiac late effects and the daily impacts of those cardiac late effects that matter most to you all. So some of the things we'll be asking, and we hope that you'll weigh in on, include thinking of all the different symptoms and concerns that you have related to the heart-related effects of cancer treatment. Which 1 to 3 of those maybe are the most significant in terms of impacting your life. We also want to know if there are specific activities that are important to you, but maybe you can't do them at all or as fully as you would like because of your heart condition. We'd like to know how your heart issues have changed over time, whether that's been over the course of a few years or for many of you, even several decades. We'd like to know what worries you most about your condition. And for those of you that are caregivers, perhaps of younger individuals that are cancer survivors, we'd like to know, knowing that quality of life for survivors changes due to these cardiac late effects, how you're empowering your children to make their own decisions about their health and quality of life as they transition into adulthood. So to get us started on these topics, we have a panel of your peers, both pediatric cancer survivors and their caregivers who will be sharing their experiences. We have Susan, Charlene, Lynn, Kelsey, and Patty, who will be providing some of this input. And I'll ask Susan to go ahead and take it away.
My name is Susan, and I live in Colorado. Betty Davis once said, "Aging is not for sissies." Aging as a survivor of childhood cancer is terrifying. 10 years ago at a routine appointment, my PCP said, "Your heart murmur is changing. Let's send you to a cardiologist." An echocardiogram revealed severe aortic stenosis. The cardiologist said I would need heart valve replacement. He explained that the stenosis was caused by the 36 gray high-dose mantle radiation I had received in 1983, when at 17, I was diagnosed with Hodgkin lymphoma. I was shocked. Cancer as a teenager had become a distant memory. The staging laparotomy and splenectomy, lymphangiogram, bone marrow biopsy, MOP chemotherapy, radiation, the impact of that brutal year seemed distant and unreal. At age 22, I had reached the 5-year survival mark. I was released from cancer care and told to go live my life. No one suggested the need for any special follow-up. Shortly after radiation treatment, I was diagnosed with hypothyroidism. I learned to live with that, along with secondary infertility, premature menopause, and constant neck and upper back pain from radiation fibrosis. In 2014, just after my 49th birthday, I had aortic valve replacement. I realized I had spent my entire life thinking I would be lucky to live to be 50. While in the hospital for my valve, I met a cardio-oncologist who saw patients in the oncology clinic. I didn't expect the strong physical and emotional reaction I would experience when entering a cancer clinic after 30 years. By the time the nurse came into the exam room, I was nauseous, shaking, and teary. I apologized and said, "I don't know why I'm suddenly falling apart." She kindly said it was common for cancer survivors to respond this way. Only 2 years after my heart valve replacement, I received my first ever callback after a mammogram. The radiologist told me the calcifications were likely benign and recommended that I follow up in 6 months. My PCP wanted to be proactive, so instead of waiting, I scheduled a biopsy. And 2 weeks later, I received the pathology report. Cancer. Again. 9 weeks after this new diagnosis, I took a leave of absence from full-time teaching and underwent a double mastectomy. I was treated with 12 weeks of chemotherapy and 12 months of Herceptin, which carries a risk of heart failure. After experiencing valve disease and breast cancer as a direct result from radiation treatment, the risk of heart failure felt all too real. I told my doctor, I know that late effects are here. What I don't know is whether I'm standing at the edge of a glacier or in the direct path of an avalanche. In 2019, I applied for disability retirement from teaching. To look at me, no one would ever guess I have serious health issues. My breast oncologist once said, Susan, you're in pretty good shape for the shape that you're in. Traveling more than an hour each way to see various specialists has become a way of life. I see a cardiac electrophysiologist, interventional cardiologist, and a cardio-oncologist. I see a gastroenterologist for esophageal issues, and an ENT for partial paralysis of my left vocal cord. The treatments that saved my life now seem to be slowly stealing it, and on difficult days, I feel as if survivorship is a progressive, terminal illness. I also see a trauma psychologist who uses EMDR to treat the PTSD symptoms that began with childhood cancer. When treatment ends, cancer is not won or done. The effects of childhood cancer last a lifetime, and survival comes at a great cost.
I am Charlene, mother to Ruth, who was diagnosed with stage 4 neuroblastoma at age 5. This year, she will be a 16-year survivor. Her treatment was everything we could do for neuroblastoma at the time for slim survival rates that were about 33%. Children with stage 4 neuroblastoma used to be admitted to the hospital and made comfortable until they pass. Now children survive, but with the damage we inflict during treatment, that child has severe effects to live with for the rest of their lives. Lifelong effects that Ruth has is decreased heart function due to damage done to her heart from the doxorubicin and chest radiation, decreased lung function, hypothyroidism, Horner's syndrome on her left side, ovarian failure, decreased tooth roots, low growth hormone, osteoporosis, bone and joint pain, neuropathy on her left arm, food allergies, skin sensitivities, and scoliosis induced by her chest tumor resection. Her scoliosis is left to right and front to back. It has been determined that her spine and chest are leaning on the left side of her heart and lungs. It is looking like 2 major chest and spine surgeries will need to be done to bring relief to her heart and lungs. With high-dose chemo, radiation, and to the primary tumor areas in her left chest, immediately caused her lung function to be about 50% and cardiomyopathy. For over 10 years, her heart function was below normal, but stable enough, not needing heart medicine. About 5 years ago, we noticed a decrease in lung function and increase in heart rate. Slowly, her chest decreasing in size, actually crushing her left side of her heart and not leaving enough room for her lungs to expand to her 50% lung capacity that she has lived with for over 10 years. Ruth is currently on Metropol and a portable oxygen concentrator at age 20. This is the lifelong side effect that hampers every part of her life. Currently, Ruth has mobility issues with any walking or standing for periods of more than a few minutes. When traveling, she has to utilize a wheelchair. With these limits, Ruth has been unable to experience obtaining her first job or go off to college on her own. When COVID lockdowns were implemented, the bombardment of fear being reported was a constant reminder of how fragile her health is, causing increased anxiety and feelings of depression. In 2020, she was hospitalized for 6 days because her lung collapsed. She recovered from the collapse, but is still trying to recover from her weight loss. Eating has been an issue, which caused her weight to be low. Her social life is affected. She is not able to keep up with her friends. Her friends are living at college or working or socializing. She's invited, but is not able many times to accept the invitations, as she is not able to walk as far as her friends do. Ruth loves to be in the ocean and canoe sailing in the past, but has been a part of this canoe sailing program for over 10 years. Current heart and lung issues has caused her not to be able to sail like she did before. When you are in the ocean, the water presses against you and she is no longer feeling comfortable to sail. Her current health is taking her confidence away from her, and she's no longer confident in the water. She also does not want to be a burden to her friends. Ruth is an avid baker and cook. If she is in the kitchen, she uses a stool as she gets tired standing and needs to rest. Ruth has had a couple of side businesses, making some homemade hand sanitizers and crocheting items. But the days that she feels well enough to do them are far and few between now, so her little side businesses have been put on hold. The function of her heart and lung affects her outlook on the future, like marriage, having a child, living on her own as an adult, and supporting herself. It is a constant balancing act to live with decreased heart function and transitioning to adult care. Parents always hold a very heavy burden on whether they made the best decisions on treatment, especially when serious lifelong effects are being experienced, like heart issues. We are hopeful that through this meeting, better treatments and even a cure will be on the horizon. Let's all work together and find this solution. Thank you for your time. Aloha from Ruth and her ohana.
Daily, I look at my child and question, is today the day? It's a thought that fights its way to the center of my heart, no matter how hard I try to keep it buried. I am constantly looking for the signs. Is she out of breath? Does she look worried? Is she nauseous? Does she have stomach pain? I know this annoys her, and I try not to be obnoxious about it, but this is my everyday reality. My name is Lynn, and I am a mom to my daughter Peyton, who was diagnosed in 2015 with embryonal liver sarcoma. Given a 30% chance of surviving her cancer, she was treated with several surgeries, 6 rounds of doxorubicin and ifosfamide, and 6 weeks of radiation. I remember asking her doctor at our first visit, what are her treatment options? The doctor replied tenderly and simply, there's only one. She proceeded to explain the cocktail that would potentially save my daughter's life and how it would be administered. She then explained the immediate side effects and slipped in that there would be long-term side effects, but we would worry about them after the initial phase of treatment. My head was swimming. That night, I woke up at 3 a.m. panicked. Long-term side effects? It was bad enough that my child was going to be given one of the harshest chemotherapies to save her life at age 10. But those same drugs might kill her at 20, 30, 40 years of age. This was the best our medical advanced system had to offer. We'll save your child's life now and condemn her to a lifetime of chronic heart issues, secondary cancers, and a host of health uncertainties. I felt betrayed. 2 days later, she was admitted and received her first treatment. As the nurse pushed the syringe to administer the Red Devil concoction, I took a deep breath and smiled as I held my daughter's hand. I had no choice. This was the only option available. This is what had to be done, come what may. It was at that moment that the mental consequences of cardiac late effects began haunting my thoughts, hopes, and dreams for my precious child. Peyton is now 17, a smart, conscientious, and beautiful young lady. We have fought hard to get her here. She is considered a cancer survivor. We have her yearly 504 review in school, and every meeting they push to remove her accommodation, stating accusingly, "She looks perfectly healthy." And I reply that tomorrow she may not be. Let's leave them in place. They have no idea of the late effect ticking time bomb inside her. Peyton goes yearly to see a plethora of doctors, including her cardiologist, to check on her heart health. It's just what we do. She takes a day off of school for each visit. We leave early in the morning, spend hours at the doctor's office as they run tests. I hold my breath every time we go, waiting for the results that will confirm she has more time until her heart shows signs of late effects. I know the clock is ticking, and I live in fear of when that day arrives. Peyton goes to great lengths to hide her cancer diagnosis. She wants everyone to think she is a completely invincible teenager, normal. And she tries to be, but she harbors intense anxiety about her body. Not the typical teenage stuff like, does my hair look okay? Deep, hidden, and isolating fear. Entering high school, she was looking forward to joining the cross-country team. She enjoyed running and would often just go off and jog on her own. The day after her routine cardiology appointment, I picked her up after her first practice, and she was inconsolable. She had felt the hard beating of her heart as she ran, and it sent her into a panic. Her thoughts were intricately compounded. Not only was she fearful of the physical pounding of her heart and the looming indication of chronic heart issues, but also the psychological realization that her teammates might learn of her cancer and think of her as a not normal teenager. The thought was too intense for her to overcome, and she quit the team the next day. It breaks my heart to know the only means of saving her life condemned her to a lifetime of debilitating chronic physical and mental issues. If only there had been a therapy that would have minimized or eliminated the cardiac late effects, my baby's life would be so different. I live with the fear of, will this be the day, and how will we manage the late effects phase of my child's cancer? Cancer is a restless and relentless disease that affects the mental and physical health of my daughter and our entire family for a lifetime. I implore the FDA, seek out new treatments that are both preventative and curative to eliminate cardiac late effects on our pediatric cancer survivors. Thank you.
Hello, my name is Kelsey. I'm 29 years old and I live in Carlsbad, California. I was diagnosed with juvenile myelomonocytic leukemia at the age of 3. I had full body radiation, chemotherapy, as well as a bone marrow transplant, which relapsed shortly after from the graft versus host disease effect, or GVHD, and with little of good Christie cells, as my mom would say. I left in my body is what helped put me back into remission. Christy being my bone marrow donor and my hero to this very day. Today, 25 years in remission and months shy of my 30th birthday, hard to believe, I have started to notice the delayed effects of cardiac issues are becoming more and more apparent to me now that I am older. The two main cardiac issues that are having most impact of my life so far would be the blood pressure and tachycardia. I first started to notice the high blood pressure in college around 2013, and my mom thought it was stress related. Granted, she was probably right, since I was up to my neck with schoolwork and juggling a job at the time. The doctor put me on medication, and it helped for the meantime to lower my crazy 150-ish blood pressure to a normal level. After about 2 years on that medication, my blood pressure leveled back out and I got off of it, and also started a new school, so that helped a lot. But then I started having issues with palpitations and chest pains. The chest pains and palpitations kind of felt like a dull, achy pain, but then they would come out of nowhere, so I didn't really know when to expect them, and it was really frustrating. One of my first episodes was back in 2015 at work, and I was just standing there doing nothing, and all of a sudden I had stabbing pain in my chest. That night really urged me to seek help because it was nothing like I had ever felt before. I know heart attacks for women are a lot different, so that definitely scared me. The doctor unfortunately couldn't figure out what was wrong or why I was having them, so that issue went unsolved. Then a year later, I started having issues with tachycardia around 2017. I feel like the tachycardia affects me the most because I don't know when it's going to happen, and it can happen at any moment as well as at any time of the day. Before I was put on the medication, the tachycardia interfered with every part of my life. Simple tasks at work, like walking up and down the stairs to the break room or standing still doing nothing. The tachycardia also impacts my life still today, even though I'm on medication. Exercising, playing sports, hanging out with my family, doing stuff outside like hiking. I can normally feel when it starts to spike, my chest will start pounding, and it literally feels like my heart is beating out my chest. Definitely not the best feeling. It definitely doesn't hurt, but it's just a very uncomfortable feeling. I've never told any of my friends about the tachycardia because it doesn't come up. Plus, I'm a very private person in my life when it comes to my medical history. Only my closest friends know about my cancer. I've told some of my family members about the tachycardia because I actually recently found out that some of my family members have the condition of tachycardia as well, and that it's hereditary. My doctor thought the tachycardia might be stress-related or situational, but he still can never figure out what was happening or why it was happening. I do have to get yearly echocardiograms to make sure my heart is healthy and functioning properly, so that does help as well. I'm no longer on medication for my high blood pressure, but the one I'm taking for tachycardia, metoprolol, actually does help with high blood pressure, so that's helping for the moment. However, I do have migraines, so when I do have a bad migraine attack or really high severe pain, my blood pressure tends to spike. So maintaining that is just a task on its own, and I have to watch that very closely. As of right now, I'm not experiencing any acute problems, but in years past, going to doctors and being told we don't know what's wrong, it's been a disappointment after disappointment. And it's like this dark cloud looming over you that there's a possibility that things are heading for the worst. And just that alone is the worst feeling in the world.
Hello, my name is Patty, and I live in Virginia Beach, Virginia. I would like to introduce you to my beautiful daughter, Abby, who is forever 15. Abby was initially diagnosed in 2011, age 4, with Philadelphia chromosome-positive ALL leukemia, and given a 20% chance of survival. Abby began a trial treatment along with chemotherapy for an intense 18 months. Included in her regimen were numerous doses of doxorubicin, which we were warned of cardiotoxicity. But at that point, saving our daughter's life was our only choice. Abby fought hard for 3 years with many bumps in the road and ultimately prevailed cancer-free. Unfortunately, Abby's cancer returned in 2014, just 1 week into her 3rd grade year. While preparing for a bone marrow transplant, a cardiologist found that she was in heart failure, even though she had no symptoms. The cardiologist explained she had cardiomyopathy caused by the previous chemo treatments. The treatments that saved her life were now compromising her life. Not only did we have a child battling cancer for a second time, but she had heart failure and her bone marrow transplant was on hold due to this major roadblock. It was a whirlwind of learning a whole new world of cardiac intensive care. We were warned that her heart medication would be lifelong and potentially would need a heart transplant in 5 to 7 years, but they were unsure as this drug was so new. We heard those words, not realizing that it would ultimately be what took our sweet girl's life. Abby's care required frequent trips to the doctors and inpatient stays, with thousands of nights in the hospital, often in intensive care. She often required air transport to a hospital that could support her cardiology needs. Abby had no quality of life and needed home nursing care for years. Abby slept propped up on at least 3 pillows because lying flat made her feel as if she couldn't breathe. This made needed CTs and MRIs difficult. Abby was homebound schooled 3rd, 4th, 5th, and also 6th through 9th grade, with a few months of being at school for a few hours at a time. As Abby's friends' independence grew as they became preteens and teens, Abby became more dependent. She frequently was exhausted and slept often. Daily, Abby had intestinal difficulties, nausea, vomiting, and diarrhea. She had a G-tube to help regulate her fluid intake. Abby was in pain much of the time, which was managed with long-term methadone, frequently requiring stronger pain medication or IV interventions. Her kidneys were hit hard, and she became a diabetic dependent on immense amounts of insulin. Abby couldn't eat what she wanted as her body didn't process things the same. Infections continued. She slowly lost mobility. Outside of the house, Abby was in a wheelchair and graduated to an electric wheelchair. Closer to the end, we often carried her within the house and had a stair lift. Being with friends, she could just sit and chat or play a game. Sleepovers and being at friends' houses soon came out of the question. Even with her few activities, we had to make sure there was someone with nursing experience present, or I stayed nearby. Abby had dreams of being a chef and owning her own restaurant. She even received a full scholarship to the Culinary Institute of Virginia. Abby couldn't stand for long periods of time and was weak, so we'd set up a place to sit, chop, and stir. But this made other parts, preparing food, more difficult. Try making dinner from a chair. IV medications helped for a while, but soon our cardio-oncologist discussed the need for a heart transplant. As we talked with transplant experts, it became apparent that Abby would not be a candidate for the transplant, and her only option was a left ventricular assist device, and there were no other kids that lived long-term with an LVAD. Hopeful that it was going to give her more time on this earth with some quality of life, Abby entered surgery on September 7th, 2021, and never woke up. Post-surgery, she suffered a stroke and passed away October 19th, forever 15. I am here because my daughter's life ended due to cardiac long-term late effects, and she ran out of treatment options. Please keep working to find more drugs that can help. Abby's tremendous fight and amazing drive to live through it all lives on in me. My greatest hope with my work and sharing her story is that other families and children do not have to go through what Abby did for 11 of her 15 years on this earth. Thank you.
Thank you, Patty, for sharing Abby's story, and to all of our panelists for sharing those stories, your journeys with cardiac late effects. I know it's not easy to share, but thank you for being so brave and being first to share during today's meeting. If you would like to share your experiences or worries with cardiac late effects, we'd like to hear from you as well during today's program. You can call in, and this is the first time we're kind of announcing this, so we're going to show you the phone number and tell you the phone number here. But you can call in at any time today at 1-703-844-3231. Again, that's 1-703-844-3231. If you would like to share your experiences with cardiac late effects, the symptoms and health effects, impacts on daily life, just like we heard so much from our panelists here today. We would very much like to hear from you. In addition, I'd like to let you know that there is, under the live stream, a comment box, so you can also submit your written comments related to these topics throughout the day, and we'll be reading those throughout the program. But to get us thinking about this topic a little bit more and to understand the experiences of our whole live audience today, we're going to go to a couple of polling questions. So if you were here earlier and you answered the polling questions, just go back to that same page. If you've just joined us, you can open a web browser on your phone or open a tab on your computer's web browser and go to pollev.com/childhood cancer. And just keep this open throughout the day. We'll be able to, the questions will automatically be popping up as we bring them up throughout today's program. So for this first question for this topic on what it is to live with cardiac late effects, here we want to know which of the following health-related symptoms or issues have you or your affected family member experienced due to cardiac late effects? And here we'd like you to select all of those cardiac late effects, symptoms and issues that apply. So the options here are A, chest pain, B, shortness of breath, C, exercise intolerance, D, lightheadedness or passing out, E, racing or rapid heart rate, F, congestive heart failure, G, fatigue, H, brain fog or difficulty focusing, I, depression and or anxiety, J, some other symptom or issue, health-related issue as a result of your cardiac late effects that isn't reflected on the slide, or K, if you are not experiencing any health-related symptoms or issues as a result of cardiac late effects. And here we want to, again, have you select all that apply. As it stands, it looks like the top health-related symptoms and issues experienced by our audience today are fatigue and racing and rapid heart rate, followed perhaps by exercise intolerance and brain fog, and then maybe as a third tier, shortness of breath and depression and or anxiety. So there is a mental health component to this. But really everything here has been selected by many of you. I should note that because our respondents can pick more than one option for this, this is not the percentages you are seeing. These are not the percentages of people who selected any one response, but instead it's the percentage of total responses. So really just think of these bars as more of a ranking, a relative ranking. We see that some of the lower, less experienced symptoms is congestive heart failure, and some others. And of course, we want to hear about those others. And we do, again, consistent with our earlier polling, know that there will be some of you that have not experienced any symptoms due to cardiac late effects yet. If we go to our second polling question for this session, here we'd like to know what are the health issues that impacted you or your affected family member the most, and select the top three. So whereas before we wanted to know the full range of different issues that you've or your loved one have experienced, here think about which has impacted your daily life, your quality of life the most. And again, select up to three of those top greatest impacts. And as you're making these selections, I want you to think about why are you selecting. We saw in the last polling question, so many, every single issue that we listed was, had a good number of people selecting each of those. So why is it amongst many different symptoms that maybe you experience, are these the ones that you're saying are most affecting you? So as it stands, it looks like some of the top health issues that you are reporting as most affecting you are shortness of breath, fatigue, and depression and or anxiety. We also see rated fairly highly rapid and racing heart rate, as well as exercise intolerance. But what really stands out to me is that every single one of these different health issues is in somebody's top three, and in many people's top three. So we want to hear from you, regardless of whether you're one of those more commonly selected top three issues, or maybe one of the more rare ones like chest pain or lightheadedness. We want to know how this impacts you in your daily life. So thank you for participating in these polling questions. We're now going to broaden the discussion. Again, we want to invite you to call in if you would like. Again, that phone number is 1-703-844-3231. You can, think about that polling question, help us understand what did you pick? Why did you pick it? We'd love to hear some of the reasoning behind some of those responses that we see. And of course, you can also continue to write in that comment box under the live stream as well. But to get us kick off our discussion today, I'd like to welcome our panel of your peers that have joined us via Zoom live today. And so let's just jump right into it. Let's thinking about that most recent polling question where we had you pick up to 3 of the aspects of cardiac late effects that have most affected you or your loved one's life. What did you pick? Maybe what is the top impact and why? And maybe we can have Jarvis kick us off in this discussion. Sorry, Jarvis, had to pick on someone first, so we're going with you.
That's fine. My name is Jarvis Quo. I am from Norfolk, Virginia. I was diagnosed with osteogenic sarcoma when I was 10. I was given doxorubicin and cisplatin. I was diagnosed with cardiomyopathy when I was 20, had a cardiac arrest at 38 and actually died for 15 minutes. And I was given a heart transplant at 40. So my experience pre-heart transplant was that I was experiencing a lot of the fatigue. I just kept going, and my body got accustomed to it. And I told my wife at the time, it's like, I'm always tired. I don't know why. And we just finally went, and they put us saying that I was having extremely bad heart failure and will be under their care for a while. So yeah.
Yeah, well, thank you, Jarvis, and I think we'll have a lot to talk to you about today in terms of your experiences over time. But on that issue of the tiredness, you said that you kind of were diagnosed with cardiomyopathy fairly early in adulthood. Were you from that point? Did you already have that fatigue, or did it take a while for you to start feeling tired? Can you give us a little bit of maybe that timeline of the onset of the fatigue?
Sure. I was 20 when I was diagnosed with cardiomyopathy. My ejection fraction was still well at that time. I don't remember the percentage wise. However, I was just I was doing quite well, actually. I just kept going. I started feeling the fatigue more and more in my early 30s.
Okay.
As I went into later adulthood, I could definitely feel that I cannot walk a long distance without stopping, taking a breath, or resting. I had a hard time keeping up with my friends. And I just thought, well, this is just me getting old. And, I just figure, well, that's just part of life. But I kept going to my doctor, and he basically showing me my ejection fraction was getting lower and lower and lower. And at that moment, they basically say, well, your body kind of got accustomed to it. Most people won't even be working at the ejection fraction you were at. So I was just kind of plugging along, as they say.
Sure. Is there kind of, maybe to put it into a little bit of perspective or context for us, were there, as you're thinking of, some of those maybe activities with your friends that you said it was harder for you to keep up with, maybe even, other aspects of daily life that just became, were the kinds of things that you noticed that you couldn't do as much anymore?
Oh, definitely. I didn't enjoy standing and cooking. That was one of the things I really enjoyed. And I always just had to even have to have a chair near me and take a break after a while, because it just became such a chore to just stand for a long period of time because of the fact that I just became tired so easy.
Right.
And it was just, I thought it was just basically me getting old, but never put two and two together.
Right. One more question for you, Jarvis. As you were, going about your daily life, would you wake up on certain mornings and say, "Oh wow, I know my fatigue is going to be worse today," or "I already feel worse today"? Were there better or worse days for you?
Not really towards the end.
Yeah.
It was just basically waking up every single day, fatigue,
Yeah.
and just, well, here goes another day,
Yeah.
just plug along.
Sure. Well, thank you so much, Jarvis, for helping us understand, that most, troublesome symptom for you. I'd like to bring Tina into the discussion here on this same topic of, thinking about, what maybe is the most of the different symptoms and health effects. What is the most problematic one for you?
Hi, my name is Tina. My daughter was diagnosed with AML at 7 years old. She's now 15. We live in the Stafford County area of Virginia. And I'm a bit nervous, so could you repeat your question, please?
Sure, no worries at all. So just thinking of the different, symptoms and health effects that your daughter maybe has already experienced or is worried about experiencing, which one maybe stands out to you as being the one that's most troublesome or worrisome?
Well, when she gets up in the morning and mentions that, "Mom, I'm just sitting here on the couch reading and my heart is pounding," that creates huge red flags. And immediately my mind goes into, emergent mode and tries to think of all the questions I need to ask. Who do I need to contact? What activities do I need to cancel for the day? How do I need to rearrange her schedule? Has she been taking all her medication? Is she doing too much? Like all of these questions. And that's just, out of the blue. The questions never stop being asked. I'm always, got an ear to, how is she doing? What is she doing? I noticed the other day that we were walking through the parking lot and I felt we were walking at what was a pretty normal clip, and yet she was 3 paces behind. And so then the question, I have to remember to write that down so I can mention that to her doctor when we meet next. And sometimes I look on the calendar and it's a countdown to how many more days before her next appointment and her next echo, because I'm nervous about what I can't see.
Right.
And her daily routines and activities, and I'm always watching. So it's never, it's not a what happens daily. It's kind of, does it ever stop?
Right.
Really, the questions are always there. The constant vigilance never ends.
Yeah, well, let me ask you a little bit about that, because obviously there's some things that you can't see, and you have to wait until that next doctor's appointment to get a read on some of the heart function and things like that. But one of the questions that you mentioned, if she wakes up and her heart is kind of pounding, you said, is she doing too much? Can you maybe tell us a little bit about that? Are there certain things that trigger her to have that pounding heart sensation? Kind of what is behind that question? Maybe tell us a little bit about that.
Sure. So she is happily a very busy 15-year-old. She has a twin sister, so there's the need to keep up with her sibling. They do drama, which is actually musicals. So there's dancing and singing, and that uses a lot of heart and lung use.
Mm-hmm.
She goes to various youth groups, and we're a homeschool family, so she enjoys friendships at cooperative youth group meeting or homeschool meetings.
Mm-hmm.
She loves to be outside. We have a trampoline, so they're, riding bikes or doing whatever 15-year-olds who typically have a lot of energy and are exploring life at the beginning of their independence would do. But unfortunately, something as simple as climbing the stairs to get from the main floor of our house to her bedroom causes her to have to stop and take a breath by the time she gets to the top before she can continue her journey around the corner to her bedroom. Sometimes she has to stop part way up. It depends on what she's been doing, what her day has been looking like.
And when you say that, just to clarify, so if she's already done a lot, is she kind of worn out or more likely to have that issue?
Yes,
Okay.
yes, definitely. And some days this is kind of what boggles my mind, is that some days we are just sitting at home, taking it easy, they're playing Xbox, they're watching movies, we're playing board games. And so nothing really strenuous at all.
Right.
Just a relaxing day at home. And she'll be lying in bed trying to relax her body to go to sleep, and her heart is just pounding. And that's, we can be sitting on the couch watching a movie, and halfway through she says, my heart's pounding. There could be no activity, strenuous or gentle otherwise. And, it just happens out of the blue. She had to have a monitor on for about a week. This was about 2 months ago,
Okay.
just to monitor her daily activity and see if there was any malfunction in the beating of her heart. And that came back normal, but we left the doctor's office with the admonition to just keep an eye on it and make notes of anything out of the ordinary.
Sure.
Ordinary, sadly, being always the pounding heart, no matter what she's doing. So
Right.
it can be scary.
Sure.
I can't tell from one moment to the next or one day to the next if this issue she's experiencing is life-threatening or just part of her daily life
Right.
now.
Absolutely. Well, thank you so much, Tina,
Sure.
for
Thank
weighing
you.
in. So I do see that we have a caller. We have Linda from Sarasota, who is a longtime pediatric cancer survivor that would like to share some of her experiences with cardiac late effects. Linda, I'd like to welcome you to the show. Are you with us?
Yes, I am. Thank you.
Wonderful. I'd love to hear a little bit about maybe some of the, in your experiences with these cardiac late effects, what you've experienced, maybe what has been most troublesome for you.
Well, I just want to offer everyone hope and support. I am a 3-time cancer survivor. My first cancer was in 1945. I had a Wilms tumor. I was 3 years old at the time. I had radiation. Chemo didn't come in until after the Second World War. However, I'm very, very thankful. I mean, obviously, I've had the love and support of my family and friends. I had good medical help. But the big thing is I had the Lord above, and I just want to encourage everyone and know that God is with you and your loved ones. I mean, I am really blessed. Like I say, I was 3 at the time, 1945, and I just had my 80th birthday. I've gone to a number of cancer conferences and all, and I just think we need to focus on the positives that we can go out. And we want to have quality of life, and just know my thoughts and prayers are with all of you. And I thank you so much that we're able to have this conference and bring people together.
Sure. Well,
thank you.
Yeah, Linda, I mean, thank you so much for being a part of this community and for, sharing, kind of your experience of, now being 80 and having been, experienced cancer treatment so early in life. Have you, is there anything in terms of cardiac impacts that you've been living with over the years?
Well, just lately, all right, a lot of us have been affected with COVID and things. A year ago in July, I was hospitalized for other things, low sodium, potassium, magnesium, whatever.
Okay.
Then I went in again.
Oh, goodness.
And problems with the AFib and heart problems and valve problems. They've been keeping an eye on it.
Right.
I had to have a cardioversion.
Okay. And the AFib, is that
one day at a time? I think there's a lot that we can do.
Sure.
Make sure that your diets are good. Stay off of sugar. There's a lot of preventative things. Exercise is so important too, even whatever they can do. And of course, children love to move anyway. Most of them, even when they are sick.
Yes.
I did end up writing a book called Dancing Cancer to offer hope and support for those who have cancer.
Yeah. Well, Linda,
so
thank
not only
you.
the children, but I find it might help with the parents to know too.
Absolutely.
We never know.
Yeah. Well, thank you so much, Linda, for sharing your journey, and that message of hope and support, I think, is heard loud and clear with all of us today. I want to check in. I know that we're starting to see some written comments coming in. Have we, Steve, are we seeing anything in terms of symptoms and health effects related to cardiac late effects?
Yeah, and I just have to say that thinking back to the panel discussion and Lynn describing her daughter Peyton's beating heart, and now I'm hearing from Tina about the pounding heart just at home, it's really struck me. We have Erin from Martha's Vineyard, who talks about how she was once a marathon runner. Completed 8 marathons over the past 40 years, and now she has trouble walking on the incline and going up the stairs. Erin also writes that, having had, being a Hodgkin's survivor for 50 years, she's had aortic valve replacement, open heart surgery, and now suffers from AFib. So you can see that for many people who thought they had left cancer behind, they're suffering from these effects into late adulthood throughout their life.
Yeah, absolutely. And I want to thank those of you that have been writing in, and will be continuing to read your input, your quotes throughout today's meeting, so keep them coming. I do want to broaden the discussion. We're not abandoning the discussion of the different symptoms and health effects we saw in those polling questions. So many of those different symptoms and health effects were listed as experienced. But I want to add in to the discussion, something that is kind of a good launching point from talking about that marathon running, and it's already been discussed by many today, which is the impacts that these symptoms and health effects have on daily life. So I do want to pull up a polling question to kind of get us thinking about this topic. So go ahead and pull out your phones, open up that browser, go to that that tab you have open in your web browser on your computer, go to pollev.com/childhood cancer. Here we want to know, what are the most important things that you or your affected family member used to do that can't be done as well or maybe at all today? And we want you to select kind of the top 3 most important things to you that are affected. The options here are A, personal care and or household chores, B, participating in sports or physical activities, C, participating in other types of hobbies, D, attending school or work, E, taking care of other family members, F, participating in family or social activities, G, traveling, or H, some other activity that's important to you but is affected due to your or your loved one's cardiac late effects. And again, you can select up to 3 of the things that are kind of the top most important things that are affected. So we'll give you a few moments to think about this. I know many of these things probably are impacted. So I know it can be difficult to say, here's the three that are the most important that have been affected. But again, we really want to get you thinking about this so that way we want to hear from you, through the phones, through those written comments to understand your experiences. All right, so while any final responses trickle in, we can see that, and again, think of these as rankings in terms of the bars. We see that the top important activity that's affected are the ability to participate in sports or other physical activities, kind of being by far the largest impact. We also see maybe as the second largest impact the ability to attend school or work. And then after that, we see, pretty much then a close follow-on of both participating in family and social activities, doing household chores and personal care, and traveling, even participating in other hobbies. No one is selected as kind of one of their top three most important things, these health issues affecting their ability to take care of family members. But we do see some other things, so we would love to hear about those as well. So again, if you would like to help us understand the impacts of cardiac-related effects in your daily life, we encourage you to call in again. That number is 1-703-844-3231, or write in with comments. But now to maybe expand and broaden this conversation, maybe we can go to Jacob on our Zoom panel. Jacob, kind of thinking about the different symptoms and health effects, and how they might impact your daily life. Maybe what stands out as something that's important to you that can't be done as well today.
So before I answer the question, just let me a little background. So I was diagnosed with non-Hodgkin's lymphoma at age 5. I'm now 51, making me a 46-year survivor. I was treated with chest and head radiotherapy and multiple chemotherapy agents, including doxorubicin, which is an anthracycline. I've suffered from multiple side effects, but in terms of cardiomyopathy and heart failure, my first episode was at age 16, after I tried to run track to, quote, get in shape. Despite this, I've been able to earn my medical degree at MPH and finish a residency in general preventive medicine, which is one of the least physically demanding. I actually dedicated my research to this topic, and particularly the effects of radiation on the heart. Unfortunately, about a year ago, I had my third exacerbation, which landed me in the hospital for a month, including a week in the cardiac ICU on dialysis.
Wow.
And another 3 weeks in the hospital. During this time, I was formally considered for a heart transplant, but was rejected due to my body size and my other health issues, including the degradation in my kidney function. Instead, I was put on a 24/7 heart medication, which I get through this pump. And basically, this medication helps the heart pump better. And it was basically, it's an off-label treatment, but the original medication is approved for supporting patients who are listed for transplant to get to transplant. So to answer your question, which was, what are the things that most affect my life? Hard to pick. I would say initially, between my first and second, was basically anxiety and fatigue, which limited my ability to be as productive as I wanted to be at work and at home. At this point, anxiety is less because I know that I have limited time. And it really, I would have to say fatigue and ability to do certain activities of daily living. Like I can no longer really comfortably bend down as much as I would like to. Like if I drop something on the floor, I also feel like I can't do really laundry anymore. Well, I can do laundry, but I can't do the dry. I can't bring stuff up to the floor where we live. So those are the things that affect me the most.
Sure. And clearly you also mentioned, choosing, a field in medicine that's less physically, or the least physically demanding amongst them. So a major, kind of life decision of career path also impacted. Can you maybe explain for those of us that may not know, what about your condition makes it hard to bend over and then therefore do certain activities in daily life that require bending over?
So heart failure can cause fluid to build up in the abdomen. And also when you bend over, you're collapsing your lungs. So that puts more pressure. The heart and the lungs work together. So when you compress the lungs, it's harder. It also compresses the heart a little bit.
Mm-hmm.
And I'm a pretty small guy. So one of the side effects that I also have from my brain radiation is that I'm smaller than I would have been. Not that would have been that tall because my parents are small, but
Yeah. And can you also, Jacob, maybe, because it sounds like you've had, impacts on what kind of physical activities you can do for some time, can you maybe describe what that looked like, maybe a little earlier in your life versus, leading up to, having heart failure today?
well, I was never. I mean, my family's never been, very, very competitive. We were never really heavy into sports, so that was part of it. But certainly, I realized, by the time I was an adolescent, that doing regular exercise might be a good thing, particularly for me. And even though I was on track for one season, I was way behind everybody else.
Sure.
And basically the season of track threw me into heart failure.
Oh, wow. Okay.
Does that answer your question?
Yeah, no, that does. And you mentioned that most recently this was your third exacerbation. Can you also maybe just kind of describe what those have looked like and how far apart those have been from one another?
So the first one was at 16. The last one, and basically it was slowly, progressively having more shortness of breath, more fatigue. So the first one was pretty early on in the identification of anticycline cardiomyopathy, so it came to us as a complete surprise.
Right.
The second one actually was complicated because I went on a bucket list trip up into the mountains,
Yeah.
which caused me to have high altitude sickness, which then they discovered something in my kidneys, which was ended up being a benign tumor, but then they took out my kidneys. So my medication regimen was changed and they had to take me off one of the better medications for it.
Mm-hmm.
And then I ultimately went into heart failure about 4 or 5 months later.
Wow.
And that was, I mean, I sort of did what Jarvis described, sort of ignoring it, but I was getting worse. I mean, at one point, I could barely get in from the parking lot into work.
Wow.
And then I waited 3 more days for my next appointment, and the doctor took one look at me and said, "You need to go to the hospital."
Wow. Yeah. Well, Jacob, thank you so much for sharing those different experiences. I want to bring Angela into the conversation again on this, talking about different symptoms and how they impact daily life, and quality of life. What maybe stands out most to you that you would want to share, Angela?
Well, so many things I could echo, and first and foremost, thank you so much for including me in this very imperative discussion. My name is Angela Lee, and I am based in San Antonio, Texas. However, I was born and raised in Virginia, so Tina, we share a common denominator there with Stafford County. I had my first diagnosis of Hodgkin's lymphoma when I was in Virginia at the age of 13 in 1984. So I'm 51 years young today, and so I'm a 38-year survivor on that diagnosis. However, due to some late-term effects, I was recently diagnosed with breast cancer and am literally 12 weeks out from a bilateral mastectomy. So that was done. Fortunately, I was stage 1. It was early detected. And although very consistent with being formally irradiated, they did not want to reintroduce my system to radiation. So rather than go with a standard of care of a lumpectomy and radiation, we avoided that route. So in my first diagnosis, I was given of full-blown chest mantle radiation, some very intense treatments to my neck, my carotid arteries, my thyroid area. And I started to experience symptoms first within my endocrine system. That radiation very quickly dissolved my thyroid when I was 16 years old. So I have been on medication to support that loss in my system. And if I can just say, hearing some of these stories, you know, for as many challenges as there have been, and I share those with the pounding heart, the rapid heart rate, a heart murmur, high blood pressure, it is amazing how the body will step in and try to adapt and adjust to those compromises. So first and foremost, kudos to the amazing miracle of the body. But I would say that, you know, for me, my primary concerns are that of heart valve disease, a heart incident, my mortality. Certainly there have been psychosocial issues involved in what, you know, how much longer can I continue to be active and do the things that I enjoy. I have experienced, you know, some limitations. My body likes to exercise, but I've also had moments of fainting. I've had to do the week-long thing of a heart monitor, only to wake a physician up at 2 in the morning because my heart rate was well over 200. And then they couldn't figure it out. And at the end of the time period of wearing the heart monitor, they just said, well, you're kind of an anomaly.
Wow.
So I've been on blood pressure medication since 30. That's really was the magical age for me. And just making sure that I'm keeping up on my lifestyle habits and doing the right things, as our caller, Linda, indicated from Sarasota. You know, that was pretty remarkable for her to say at the age of 80.
Right.
Just, you know, lifestyle habits do have a play in that. And so does a positive mental attitude.
Yeah.
So I would say that I've been fortunate in that I've been proactive, but certainly I worry about some of the concerns I mentioned with heart valve disease, congested heart failure. It was in a routine sonogram that I had on my thyroid area. As I've learned, even though you don't have a thyroid, you can still get thyroid cancer. Oftentimes you can get nodules that are benign, but you still have to have that area surveilled. And it was in a routine sonogram in my early 40s. And they said, it was a technician for the sonogram for my thyroid. And she said, do you have a cardiologist? And of course I said, yes, I see my cardiologist twice a year. And she said, well, I didn't tell you this, but I think you need to have a sonogram on your carotid arteries. I took that information. I got that screening done. Turns out I had a 50 to 60% blockage before I was 45 on both of those arteries. So I have been on a statin at a very low dose, you know, for the past 11 years. And again, it's just been kind of a trial and error with medication. I've been on metoprolol. I know that's been mentioned a couple times. I've been on 150 milligrams of that now for about 20 years. I've also been on losartan.
Yeah.
Another blood pressure medication as well. So that's kind of it. I can't even say in a nutshell because that's a lot of information.
Yeah. Yeah. Well, there's, you know, very interesting because, you know, you mentioned that you really enjoy, you know, being active, and you also talked about how being active is can be so important for helping, you know, being healthy. You know, but sometimes, you know, the condition itself can make being active hard, and you mentioned that you know, there are certain activities that you are worried you won't be able to continue doing. I was wondering, you know, is there an example of, something that already is impacted and for which you're concerned, if the kind of condition progresses or worsens, may be something you're not able to do, at all or in a way that, you would really want?
Definitely the stairs. For some reason, that incline, it has been inconsistent when I have brought it up to my cardiologist because my echocardiograms look normal. My nuclear stress test, wow, you knocked it out of the park. It's a little bit of a roller coaster.
Okay.
But I have noticed that when I've had, when I've passed out, I've had lightheadedness, it has been associated to some type of elevation. And for that, I worry. I think this is a common survivorship mentality, but I want to go. I want to do. I have all these things I've got to get done because every day is a gift. And so one of my bucket lists is to climb Mount Kilimanjaro. And I don't realistically know if I'm going to be able to get there for that very reason of
Right.
having the stress to my pulmonary system.
Sure. And is there
So,
anything?
I've had medication reactions too that affect my pulmonary and my breathing. And again, once you climb a flight of stairs, you know real quickly if that's an issue.
Right. And knowing that you've had some of these issues with climbing stairs and associated with that, fainting is not to be taken lightly. Has there been anything in life that you've had to dial back or avoid or kind of maybe just change the way you approach something in life, knowing that that could be an issue, something that could happen on any given day?
I have to just, to be honest, I have my husband and he kind of reels me into reality from
Sure.
time to time. If I were allowed to go at my own pace, who knows where I'd be? I might be very injured. But I have to recognize that when I'm tired, I need a nap.
Yeah.
There could be something else, be careful of putting in a level of effort that might seem average
Right.
to the average person my age, because I'm not average with the health experiences that I've been through.
Yep.
So it's kind of like I have to think before I do.
Right. A lot
I
more.
know that sounds really trite, but that's the truth.
No, yeah, you can't, kind of go with the flow or be, just do something on a whim if you have to plan so much more in advance and know more about the, landscape you're going to encounter or something like that. So thank you so much, Angela.
Thank you so much again.
I see that we have some phone callers, so I want to bring them into this discussion. I'd first like to bring in Sarah, who's from Norfolk, Virginia, and is a survivor, and like to share some of the impacts that cardiac late effects have had on her life. So, Sarah, I'd like to welcome you to the program. Are you with us?
I am with you. Thank you so much for having me.
Yeah, well, welcome. What would you like to share?
Well, I am a two-time childhood leukemia survivor. I had biphenotypic leukemia, which is both ALL and AML leukemia, when I was diagnosed at 14 and was in remission for 6.5 years, and then relapsed with the same form of leukemia. I then underwent full body radiation in preparation for my life-saving stem cell transplant, and I will be 12 years post-transplant this coming Wednesday.
Wow.
So that's very exciting, very happy to be here. However, it's not without its challenges. When I took the poll, the most recent poll about, what was it? It was like, what are the most important things to you that I can no longer do?
Yes.
One of the big ones that has been really hard to accept is carrying a child. I am postmenopausal due to my treatment. However, I could carry a child, and as a child myself, I had always wanted to be a mother.
Sure.
I was one of those kids that if you asked, what do you want to be when you grow up? I always said I wanted to be a mom. And unfortunately, after, going to multiple different doctors and really talking about the nitty-gritty of how I would be a high-risk pregnancy due to my cardiac late effects. They kind of left it up to me. They didn't recommend it, obviously, because of my cardiac late effects. And it took a while for me to fully comprehend it, but I ultimately decided that I will not be carrying a child or becoming pregnant due to my cardiac late effects. And that has been a really hard journey to be on. And it's just, I wrote in a comment that, you know, when I relapsed, I was an adult, and I had to sign all the papers that told me of the late effects and everything that could be caused because of the treatment that I had. And I refused to read it because I didn't need to know at that time. And if the only other option is death,
Right.
then we need more options.
Right.
So, yeah. So
Wow.
I'm relatively a healthy person. I am very exercise intolerant. I'm heat intolerant. I'm postmenopausal. But really the hardest has been because of my cardiac late effects. My dream of being a mother looks differently than I had planned my entire life.
Yeah, I can't imagine how difficult that must be. You know, if you're comfortable, would you be willing to share with us, you know, how that, you know, really significant impact may have also had, you know, either social, mental, or emotional, you know, impacts on you as well?
Sure. So because of my cardiac late effects, I already experienced, you know, at the risk of sounding like a broken record, hypertension. I take 2 different blood pressure medications. I have anxiety, and I wasn't actually treated for these things until I went on this journey of trying to become a mother. And I think that it's definitely caused multiple mental struggles as well as social struggles. I mean, I'm 33, so all of my friends are now becoming pregnant and moms, and it is just really difficult. And it's something that, again, there was no other option.
Right.
When I was originally being treated, that protocol was over 40 years old at the time.
Right.
And that was the only protocol that I could be put on. So it's just very important because our children that are being diagnosed and treated they have their entire lives ahead of them.
Yes.
And it's so important that their life, after everything they've been through, their life should be a breeze. And it turns out that it's not.
Absolutely.
So,
well, Sarah, thank you so much.
I don't know if that answered the question.
Yeah, no, it does incredibly well. And, you know, I want to thank you for raising this impact first and foremost, and being willing to share so much of kind of the personal impacts of it. So thank you again for calling in. I would like to now bring in Erin. I think we may have actually seen one of her written comments, but she may want to follow up a little bit on that. This is Erin from Martha's Vineyard, who is our marathon runner. So Erin, I'd like to welcome you to the program. Are you with us?
I am. Thank you. Can you hear me okay?
I can.
First, I have to apologize because I also have vocal cord paralysis, so I'm not always easy to understand. But I just want to make a couple comments on what I've been hearing.
Yes.
I guess first and foremost, to hear some of the panelists, the parents of kids in particular, I am completely humbled by your stories. I heard the speakers talk about their children's experiences, and I heard my comments read about running marathons, and I thought, gosh, if I were a parent of one of those kids, I would give anything for my child to have lived long enough to have done some of the things that I've been able to do. And it has not been easy. It's been a long 50 years of struggling with different issues, but I am completely grateful for the time that I've had. It was 45 years more than I was told I was going to have. But I just wanted to say my heart goes out to you, and I wish I could do something to give you back some years of your children's life. I would greatly do it. And then the other thing I just wanted to say is that I happen to be a part of an organization, a nonprofit for long-term survivors of Hodgkin lymphoma.
Mm-hmm.
And by far, the most concerning thing we hear from them is the cardiac effects of their earlier treatment.
Yeah.
That is the one thing that folks struggle with the most. Lots of problems with valve issues, and I think some of this has to do with the previous treatment for Hodgkin's, but that is very common.
Sure.
So just to, say that this is something that is near and dear to our hearts, to be putting it mildly.
Right.
But I think what I have learned over the years is that sort of like that saying, if you see something, say something. If you know your body well, you know something's not right, say something. If you don't get an answer that's compassionate and takes your concerns seriously, go find somebody else.
Yeah.
Because we still fight the battle of not being understood and in some cases not being believed. And I think that comes from, a state of not willful ignorance, but in folks just not knowing in the healthcare business, not knowing what long-term survivors are up against.
Right. Well,
And that would just be my plea, is to hear us, believe us, and for those of you who are struggling, to not be afraid to say this is real.
Yeah, well, Erin, one thing you said, well, first I want to just first and foremost thank you for following up and calling in, as well as writing in, and know that, participating in this meeting today and other activities, are really important to help, kind of change, what has been the status quo that we have been hearing so much about today. So really thank you for being a part of it as a way to help change the future for these kids. But one thing that you said that was, if you see something, say something. And so for you, I know we had read a little bit about your experience and the impact on your physical impacts, but if you're thinking back to when you first noticed that there was something wrong, can you tell us a little bit of what that looked like? What was the kind of see something for you?
Sure. Well, it actually, quite honestly, was from running. I was still doing marathons and noticed that I was getting progressively lower. And I'm not, I'm not a rabbit. I'm in the back of the pack. So it didn't come as a surprise that I was doing things slower. It was taking me more time. But my husband actually pointed out to me that I had slowed down quite a bit, and I often had to stop when we were out on a run. And I was surprised by that, because it kind of crept up on me. And by the time I went to see a doctor, I had severe aortic stenosis.
Oh, wow.
And the first cardiologist I saw, did take note and sent me on to another specialist. And I ended up having open heart surgery. Yeah. And secondly, I'm now in a tricuspid trial. I had tricuspid surgery last year.
Okay.
So problems continue, but it was definitely from just, seeing and feeling my slow down.
Absolutely. Well, Erin, thank you so much again for calling in and also writing in and sharing. We encourage all of our audience today, feel free to, chime in multiple times. We'll hear different pieces of your experiences and your thoughts, and that will help tell this broader picture of what we're trying to understand. I do want to check back in with Zoom. Mary Beth, we haven't had a chance to hear from you yet. Thinking both about, the different symptoms and health effects and impacts on daily life. What are some of the major concerns in your experience?
Well, good afternoon, everyone. I feel very privileged to be a part of this group this morning. I live just outside of Baltimore in Bel Air, Maryland, and my son was diagnosed at 1 year old back in 1999 with neuroblastoma. He's now 25 years old, but the road from there to here has not been easy. It has been laden with a lot of long-term side effects, a lot of very difficult side effects. And for him, his cardiomyopathy was diagnosed at the age of 14. Right in the middle of a tsunami of side effect experiences. Some side effects had disappeared and come back with the onset of puberty. Some of the side effects that we were continuing to experience had gotten worse. And then unfortunately, we were dealt a new list of additional side effects, cardiomyopathy being one of them. So that's an awful lot for a young tweener, emerging teenager to have to deal with. And because I think it needs to be said, done without psychosocial support. The psychosocial standards for children and families needs to be instituted in all of our hospitals because we had nothing. So we were dealing every day with whatever the side effects were at the moment that was, screaming for the most attention, barely able to catch our breath. And I don't know how my son got through the day. I'm not exactly sure how I got through the day. But somehow from there to here, we've been able to struggle through and do what needed to be done. When he was diagnosed, and it wasn't one of the side effects that was listed, but definitely an important other, was inflammation in his ankles. We were experiencing a lot of the fainting, lightheadedness, fatigue. But when you're dealing with a lot of different side effects, it's kind of hard to tease everything apart. So you're dealing with side effects, not really quite sure exactly what is it speaking to. Is it speaking to GI issues? Is it speaking to the fact that he was having a lot of executive dysfunction? He was diagnosed with chemo-induced ADHD. So the poor thing barely could get through the day just managing basic things. So hard to say how much of some depression or anxiety could be single-handedly pointed to a cardiomyopathy.
Right.
But in the end of the day, he was a soccer player. Because of profound hearing loss and because of bullying, he ended up leaving the soccer team and he started to skateboard and really was putting a lot of time and attention into it. But what I found later was he was wearing 2 and 3 pair of socks to try to hide how swollen his ankles were, and had started asking to have shoes larger than what he normally would wear, so that it all could appear on the outside that everything was fine.
Right.
And we were in the car driving home from a day of skateboarding, and his friends actually brought it up. And when the friends are bringing it up, there's a lot of concern and a lot of worry for your child. And he tried to slop it off. Oh, I'm a skateboarder. These are skateboard anchors and ankles. And one of his best friends looked at him and, dude, skateboarders don't have ankles like that. And that's when I told him, when we got home, we're going to the hospital tomorrow. This is terrifying.
Right.
And we went, and it started to piece together some of the symptoms that we were seeing. Very frightening that at 14 years old, my son was diagnosed with cardiomyopathy at the same time that my 75-year-old father was dealing with a lot of heart issues, both on heart medication, both dealing with inflammation, both dealing with fatigue. He saw a lot of himself in the mirror of a 75-year-old man. And without psychosocial support, that really was a problem that my son really, really, really struggled with, because 5 years later, my father died of his heart issues.
Yeah.
At that point, my son, and I completely respect it, he said, I can deal with the profound hearing loss, I can deal with the GI issues. He can't deal with the cardiomyopathy, and said, no more. I'm not taking medicine. I'm not getting my heart tested. And he basically pulled a stop and said, here's what I can do and here's what I can't do. And I respected that. But I did ask our nurse practitioner, I said, when this happens, what do I do as a parent? And she said, it's actually common that this happens.
Sure.
And she said, there are times that you have the luxury to bring them back because you see a side effect that you can get tested. She said there are a lot of children that as they transition into adulthood and are young adults, the ambulance brings them back. And that's what gets them back into testing. And that's what gets them back into routine monitorization of symptoms.
Sure.
And I would say, even though we're able to monitor some things, my son feels they're a little bit more approachable. This may be one of the things that the ambulance brings us back because he can't do it. It's too much. So we watch fatigue, my son's a musician and that is one of his savings graces. And so as long as he's playing his drums and he's getting together with his fellow musicians and playing in his concerts, I know life is golden.
Yeah.
If he's canceling those types of things and he's sitting on the couch, if he's staying in bed, it puts a mother's heart to great worry because like you've already heard from other mothers, it brings back what gets put off to the side, that gets front and center, that says, is this the day the world changes again? Is this the day that suddenly now this issue is something that's going to start screaming that it deserves attention? Or even worse, is this the day that quality of life changes forever? Because now we are farther down the line on this particular side effect that robs them of quality of life. So we do the best that we can every day. And really, I think my son's attitude is he hangs on for dear life to the best quality of life each and every day.
Yeah.
And if tomorrow's side effects say we've got to change that, that's a decision to make tomorrow.
Right. Mary Beth, thank you for sharing this. I know this was one of the topics early on we mentioned we really wanted to hear about is that transition as these children are becoming adults and are autonomous and making decisions for themselves. What that transition looks like. When you're dealing with these really these physical and things that maybe you feel, some things like the swelling that you see in daily life. In terms of your son's coping, with what he's dealing with, have you seen that he's found, some of his own avenues for coping? Has he found some social support? You kind of told the story of the skateboarders maybe weren't the most supportive, at that maybe a little bit younger age, but just kind of, want maybe to reflect on that a little bit if you would.
Absolutely. I think our children, and as they transition to adults, they're people first. They need their friends. They need their family. As long as quality of life allows them to be with them, they're getting important support. It's when quality of life forces them to stay at home or worse in bed,
right,
that they really are isolated. And those are the moments where they really, really struggle.
Yeah.
As I said, he's got a number of different side effects. So he was put on medical marijuana when he was 18. Cluster migraines are one of the issues that he has, and he was on home hospital care all through high school for that. One of the benefits that I have seen with the medical marijuana is a reduction in his stress. It's allowed him to be able to manage with things. And again, that psychosocial support. Children need to be able to manage stress. And we as family members we all need to heal a little more and reduce the stress that we struggle with when we're tackling all these different side effects, because the stress amps up all of it. One of the things, and I do say it's probably the most influential for his quality of life, was the pandemic, because he was struggling, attempting to do work and attempting to do some music, and he couldn't manage. His executive dysfunction was extremely debilitating. And the pandemic was full stop on absolutely everything. And he basically has an efficiency set up in our basement. We're not sure if he'll ever be able to live entirely on his own. So he basically has his own space in our basement.
Yeah.
And just being able to stay there play his music,
Yeah.
be more intentional about the way that he spent his days, brought that stress level so far down that what we've enjoyed since the pandemic has actually been a minimization of a lot of symptoms.
Wow.
For me, it just really speaks loudly to and entertainment and social.
Yeah.
There are times based upon the kind of music that he's listening to or the kind of music that he's playing that I can tell kind of what's going on and the purpose of it all.
Absolutely.
And then me, of course, trying to be there in whatever supportive way that I can to help him remember that he's not alone, that he does have somebody to talk to be able to try and bring out and reason together some of the things that are going on. And I think that that really has been helpful, especially on the days when he is stuck at home.
Right.
Or worse in bed, or I mean, there's sometimes he's sleeping most of the day when things are really, really concerning.
Yeah.
And then we sit and talk about whether or not it's a day that's worth getting in the car and going back to the hospital.
Oh, I see. Yeah. Well, Mary Beth, thank you so much for shedding so much light, on this issue of, kind of transitioning and coping. It sounds like it's a journey that you, both he and you are both on still together. So thank you so much for sharing that. I do want to, we've got a limited amount of time left in this morning session. Do want to add in one final topic to comment on, which is we've heard so much about what everyone has already experienced, what you're currently experiencing. In that, many of you have already expressed, worries and concerns for the future. But we do have a polling question on that topic. So this will be our last polling question for this morning session. So you can go to your web browser on your phone, open that tab on the web browser on your computer, go to pollev.com/childhood cancer. And so here we want to know, what are the issues that worry you or your loved one the most about, your or their heart disease in the future, knowing, and thinking about, life with these cardiac late effects in the future. And so here you, again, can select up to the top 3 issues that perhaps worry you the most or worry your loved one the most. And so the options are A, academic and career success, B, the ability to live independently, C, the lack of social interaction, D, finding a lifetime partner, E, mental and emotional health, F, worry that the symptoms will get worse, G, worry that you'll need heart surgery or a heart transplant, H, having children, I, the inability to travel, J, the worry of sudden death and or having a heart attack, or K, some other issue that worries you the most about your heart disease in the future. And again, you can select up to the top 3 greatest worries. So we'll give you a few more moments here to think about this question, get your responses in. So as it stands, it looks like the greatest worry of our participants here today is the worry of needing heart surgery or a heart transplant, followed closely by the worry of sudden death or having a heart attack, and that symptoms will get worse. We do see very close to those is the worries about mental and emotional health. We've started to hear a bit about that already this morning. But close right up there with some of those really physical, and direct medical worries that are in the top 3. We do see several other of these issues in several people's top 3. We see the ability to live independently being, one of those, as well as academic and career success, finding a life partner, having children, and being able to travel. No one selected lack of social interaction or other as one of their top 3 greatest worries. As we're thinking about this, I want to check in with Steve. I know, whether it's, kind of issues that have already been experienced or worries for the future, have we been seeing any written comments on these topics?
Yeah, and you go back earlier in the conversation when Lynn was talking about her daughter Peyton and that sort of ticking time bomb and worrying about the day, you know, she would have to confront potential cardiac late effects, or Kelsey talking about that dark cloud hovering.
Yes.
We got a comment from Elisa in Italy, who is a Hodgkin's lymphoma survivor, received chemo and chest radiation when she was 17, almost 23 years ago. So now she's developed breast cancer, and says, you know, my heart seems to be okay now, but I need to start hormone therapy, and I'm afraid how it could affect my heart and speed up any secondary effects. So I think that constant concern of late effects resulting from secondary cancers and that sort of overall uncertainty is something that we're hearing.
Yeah, absolutely. Well, thank you for those who have been writing in, and we'll continue to check in with any written comments that we're seeing. I do see we also have a phone caller, Greg from San Antonio, who's a pediatric cancer survivor and would like to share some of his experiences and worries. So Greg, I'd like to welcome you to the program. Are you with us?
And thank you for having me. Can you hear me okay?
Yes, can hear you loud and clear.
Okay, perfect. Yeah, it's interesting that last poll with the approximately, you know, a quarter of the patients saying they were concerned about having heart surgery or heart transplant. So I had Hodgkin's disease approximately 30 years ago, and then about 18 years after completed therapy, had open heart surgery to replace my aortic valve and bypass 3 coronaries that were 95% blocked, and then have subsequently just really continued to deal with, you know, cardiovascular issues, with a mild stroke in my kind of early 40s or late 30s, another valve that's failing, and then now being on medicines for congestive heart failure. So it really has impacted my life, and it's not something I pretty much think about it every day. With you know, things like, am I going to avoiding stairs, taking the elevators,
right?
When we're on vacation, really thinking about, you know, a certain path we're going to take when we're walking somewhere, just to not stress my, you know, heart. I believe my cardiologist told me I'm a walking cardiac event, which is kind of scary to hear that, but it's reality. And I take a lot of medicine daily just to maintain, you know, my ability to function. But, you know, overall, I feel blessed to be here, but being on this, you know, this really important discussion about patient kind of perspectives and outcomes, I think it's really important to stress that, you know, as oncologists, I don't think this is the outcome that we're really shooting for long term, and that it's, I think, super important just to hear, you know, patients across, you know, the country and the world, what their experience with respect to these outcomes, because I don't view it as a complete victory yet if we have patients that are in their 30s and 40s having to go through some of these, you know, things like heart surgery. Those are scary and life-threatening, but also difficult physically and mentally. So just, you know, I think we're all shooting for the day where we don't have, you know, this type of outcome for our patients. And so I think about it every day. It affects my life. I can use lifestyle modifications to, you know, live a really good life and have a high quality of life, but not everybody, you know, has access to the good medical care and the expertise giving advice to, you know, kind of maximize their outcome, you know, knowing that there's, you know, cardiac problems for a majority of patients. And discussing this today is, I think, outstanding.
Yeah. Well, Greg, if you don't mind me asking, you know, as someone who has had a heart transplant, and, you know, as you've described it, you know, you can have, there's a lot of lifestyle modifications that allow you to, you know, navigate daily life. You know, in light of all of that, you know, what remains maybe your biggest worry, you know, as you think about the future?
Well, so just to clarify, I had open heart surgery. I haven't had a heart transplant yet.
Okay.
You know, that's honestly something I worry about is what's, because, you know, my mitral valve, I had an aortic valve replacement, and then my mitral valve, which is on the same, the left side of the heart, is also, you know, not in great shape and possibly needs to be replaced. And I have very bad lungs as well from the radiation. And so it's just the whole heart-lung situation makes it probable, and I'm probably going to have some type of surgery again. And
Right.
when would that be? I worry about that. I mean, I think anybody would worry about that.
Yeah.
And it's just, hopefully never a heart transplant, but that's something that may happen. And you cross that bridge when you come to it. But in terms of dealing with it, I think it's trying not to let the possibility of those kind of difficult obstacles totally sidetrack your daily life, because that'll come when it comes. You have to, I think, live each day and not try to get wrapped up in what may be coming down the road, and just try to maximize the time when you're feeling well and try to do some things.
Yeah. Well, Greg, thank you so much for providing that perspective. I know we're just at time here, but I know we have our Zoom panel. A couple of you had wanted to say something about worries for the future. So I'll just ask if you can be very quick with your comment, but I will give you the final word here as part of this morning's session, on what is your top concern for the future. Perhaps we can start with Jarvis.
Sorry, I had to unmute myself. My continued concern is still that even though I had the heart transplant, that now I am still within to see my own mortality, because heart transplant don't last forever.
Yeah.
They do have a expiration as well. So I continue to deal with mortality issues as being a young cancer survivor. It's always looking out at I want to say the Grim Reaper is always on my back. And it just, even though I'm living my best life possible, thinking something could happen always worries me.
Sure. Thank you, Jarvis. Tina, how about you?
I just wanted to say that, there are a myriad, millions and billions of concerns for the future, but the biggest one is this: my daughter, who's 15 and spent 8 years of her life battling cancer and its subsequent, post bone marrow transplant effects, like that were top of the line, had to be addressed immediately. But the ongoing effects, like, is this her best time at 15? Is this, and is it going to get worse from here, or is there something on the horizon? Is there something we can do to help these kids live stronger, better lives without having the constant worry of mortality at a very young age because of a medication they needed early on? Hopefully about to come through to help them continue on with their best lives.
Right.
into a old and happy adulthood.
Yes. Thank you, Tina. And Jacob?
So I really had two thoughts. I totally reiterate what the prior speaker said. I think before I got into the condition I am right now, I think every time I had a cold, every time I was a little short of breath, I was always worried. Is this it? Is this the next step downward? On the other side, at this point, I've been able to accept more of my mortality, and certainly can find a silver lining. Certainly being in the hospital for so long, and knowing that I probably was going to get out, and certainly helped focus me on what I wanted my legacy to be. It's crappy that at 51 I have to think about this, but at least I was able to focus, and luckily I was able to get out.
Yeah.
And then be able to accomplish that with whatever time I have left.
Yeah.
And just be thankful for the time I've had.
Yeah. Well, thank you, Jacob. And Angela, I saw you wave your hand there. Final thought on worries for the future?
I pretty much, I appreciate what Tina has said. Looking back, that was where I was when I began my journey. And so for City Consolation at 51, you know, I'm here, Jacob's here, but also to echo what Jacob said, you know, I too, I've accepted my challenges. I've accepted my mortality. I certainly don't wish for anything sudden, and I certainly will continue to be as proactive as I can.
Yeah.
But I look to the children of Mary Beth, of Tina, and say, that's where I want to see a reversal. I want them to be 51 and have fewer problems. I want them to be 51 and have the FDA and whomever have a standard of care and a procedure in place, or whether it's an oncologist, another specialist, a general practitioner. There's something there that talks to their treatment and their long-term care. And I know things like that are evolving, and they have been evolving for some time now. So we are making progress. But I would say that my future concern is on the people who will grow up one day, be in our shoes, be in my shoes at this age, and hopefully they're thriving in ways that maybe I haven't been able to, and they're having answers a lot sooner.
Yeah, well, thank you so much, Angela, for adding that as well. I want to thank our whole Zoom panel here. I want to thank everybody that wrote in, called in, answered one of those polling questions. It's been an incredible morning of understanding the experiences of this community and living with cardiac late effects of pediatric cancer treatments. This is only half of the day. We're going to take a about 25-minute break. We're going to be coming back at 1 p.m. Eastern to resume the conversation and build on this discussion as we transition to talking about both current and future approaches to treating these cardiac late effects. So again, thank you all, and we look forward to rejoining after a brief break. Good afternoon. My name is James Valentine, and welcome back to the externally led patient-focused drug development meeting on cardiac late effects in pediatric cancer survivors. I'm joined here with my co-host Steve Wasala from Children's Cancer Cause, and we want to welcome you back after a wonderful morning discussion to really help understand what it is to live with cardiac late effects, and in this afternoon session build on that as we talk about current and future treatments. But before we do, I'm going to pass it over to Steve to welcome our afternoon speaker.
Thanks, James. We had a great morning, and it's now my pleasure to introduce Dr. Saro Armenian, the Baron Hilton Chair and Professor of Pediatrics, and the Director of the Division of Outcomes Research in the Department of Population Sciences at City of Hope Comprehensive Cancer Center. Dr. Armenian also directs the Center for Survivorship and Outcomes in the Hematologic Malignancies Research Institute. Dr. Armenian has achieved international recognition as a physician scientist focused on improving the health outcomes of childhood and adult onset cancer patients. Dr. Armenian also represents one of our partner organizations, the American Society of Pediatric Hematology Oncology. He'll share today with us emerging paradigms to consider in cardiovascular disease in childhood cancer patients and survivors. Dr. Armenian, thanks for joining us.
Thank you for that introduction, and a special thank you for Children's Cancer Cause for organizing this meeting and for the invitation. So as you've heard earlier today, childhood cancer survivors are at high risk of developing cardiac issues and cardiovascular issues, including cardiac dysfunction, where the heart's not pumping adequately, otherwise, and more severe states is known as heart failure, cardiac arrhythmias, accelerated atherosclerosis or early myocardial infarction, as well as valvular disease. We know that over time, a number of chemotherapy as well as radiation treatments can accelerate the risk of cardiovascular disease, and this is largely because that there are cellular damage that's happening at the time of cancer treatment, either at the muscles of the heart or the blood vessels that supply the heart. We're starting to recognize that even with emerging therapies such as CAR T therapy and other cellular therapies, the risk of cardiovascular disease is not zero. And we know that there are emerging signals that are developing in the adult world that we should be paying attention to. So this is data looking at adult patients receiving CAR T therapy for leukemias, and what they actually show that the severity of acute complications such as cytokine release syndrome, which is the cytokine storm that many of our patients who receive CAR T therapy have, will put you at risk for developing cardiac dysfunction during treatment. What we don't know what happens to individuals who develop cardiac dysfunction during treatment, what happens to them 2, 3, 4 years later. There are definitely emerging signals for us to be aware of that not all new treatments are potentially safe in the long-term survivorship journey. So why are cardiovascular issues prevalent and why are they happening in many of our patients? The reality is that many of us, all of us, have this intrinsic cardiovascular reserve capacity. And it's essentially sort of like the fuel in the tank. And this cardiovascular reserve capacity helps us meet the everyday requirements of physical work and play, and is able to help us sort of counteract some of the balances and shifts that happen on the workload of the heart. Now, this is maintained by healthy hearts, lungs, muscle, and oxygen carrying capacity, all of which can be impaired during cancer treatment, either as a result of direct exposures, such as chemotherapy, targeted agents, and radiation that deplete this cardiovascular reserve, or indirect risk factors that emerge in aging patients, such as hypertension, obesity, dyslipidemia, and diabetes. So, what does this look like in terms of figure? In the red line is the normal trajectory of decline of cardiovascular reserve in the general population. So all of us, as we age, there's a steady decline in cardiovascular reserve until we enter our 8th, 9th, and beyond decade of life, where there is depletion of this cardiovascular reserve and manifestation of cardiovascular disease. For our survivors, what we think happens is that there's a rapid depletion in the reserves, and then the change in the trajectory of this reserve and decline such that the depletion happens at 10 to 20 to 30 years earlier than what you would expect for the general population, hence early onset cardiovascular complications. Why is this important? It's important because when we think about cardiovascular disease and how we think the paradigms to manage it, we recognize that when these issues are happening in yellow, the incidence is increasing over time. But at the time at which it's increasing, the engagement of our survivors in cancer-directed care as well as survivorship care declines. And so this is not that they're not engaged in care. They are primarily being seen by their primary care providers. So more than 95% report seeing their primary care provider in a regular setting. What happens is that there's a transition away from the cancer center to the primary care setting where a lot of the screening and surveillance may not be happening for our patients. And I'll give you an example why this is important to engage our patients and our survivors early. It's because they have risk factors that are different than the general population. So risk factors for cardiovascular disease, such as hypertension. Here, this is data from the CCSS, the Child Cancer Survivor Study, showing that the prevalence of high blood pressure in survivors in blue increases dramatically after cancer treatment at a much higher rate than what you would expect for the general population. Now, hypertension is a silent risk factor, so it may not be picked up if survivors are not being screened for appropriately based on their age. Why is this relevant in the context of cardiac issues? Well, survivors who have hypertension as they get older have a greater than 30-fold risk of developing heart failure if they've already been treated with anthracycline, and that's the blue line that you see on the right. So anthracyclines combined with hypertension that develops later in life will put you at risk for greater than 30 times the risk of developing heart failure. What can we do about it? Studies in the general population have shown us that the more aggressive you are in blood pressure management, lowering that top number, the systolic blood pressure, the lower the risk of cardiovascular disease. And randomized trials, you can actually, the study investigators have shown that you can reduce the risk of cardiovascular disease by 25%. And likely it's probably going to be even more in our own survivors. So aggressive management of risk factors is key. So how do you do that in a survivor population that's very mobile, that only comes to clinic potentially once a year, or survivorship clinic once a year? The reality is you can actively manage many of these risk factors remotely. And COVID, as well as advances in technology, have really greatly facilitated our ability to bring in mobile technology to monitor patients in real time, whenever, wherever they are. And at City Hope, we fully embrace this more holistic approach of survivorship care, where it's not just an annual visit, but the long-term follow-up that happens in real time. So we give our patients who are at high risk glucometers to check their blood pressure monitors that are Bluetooth enabled, physical activity monitors, scales, pulse oximeters, and then we have real-time triaging that we can do through a centralized nursing system. And this real-time triaging will allow us to address issues in real time and also implement behavior change, not just at the annual visits, but as the patients are sort of living their everyday life. And that has to be a part of the conversation from long-term monitoring. Well, how about exercise? Well, we know from survivors that were seen over multiple decades of that the more active you are, the more intensive the exercise is, the more frequent the exercise is, the lower the risk of cardiovascular disease. And in fact, if you actually just follow the basic CDC guidelines for exercise, as a childhood cancer survivor, you can reduce your risk of cardiovascular disease by greater than 50%, so over half, which is really remarkable if you think of that. Again, when we thought about exercise in the past and how do we train our survivors to optimize their health, a lot of our strategies were primarily center-focused, cancer center-focused. We recognize that geographically, that's not necessarily feasible for many of our patients. And in the context of COVID and space limitations, that may not be a realistic strategy, especially considering the growing population of survivors. So we have fully embraced tele-exercise as a way in which we can communicate with our patients remotely, deliver exercise prescriptions that are tailored around their own physical impairments and their physiologic needs. And we can do this across dozens of patients simultaneously, which kind of obviates the need for space at an institution-based gym or at a nearby facility. And this real-time monitoring and coaching is really integral to the behavior change that we need to implement in our patients. Well, how about early screening? Can you pick up heart disease early on and maybe act earlier than you would if someone develops clinically symptomatic disease? So Kevin Effinger and colleagues did a randomized trial to see if we can optimize cardiac screening and early pickup of cardiac disease for survivors. And what they did was they randomized patients to advanced practitioner-based coaching and counseling and versus standard of care. And what they actually found is that engaging survivors remotely through coaching with an advanced care practitioner about the importance of early screening and monitoring for cardiac disease with an echocardiogram, they were able to nearly more than double the likelihood of someone getting a recommended echocardiogram. But what you'll note is that that still is only half of the patients. So what are the limitations for why the remaining half did not get echocardiograms despite being told to get them? And the reality is that there are real logistic issues, insurance coverage issues, access to advanced imaging that may not be available to many of them, especially if they're living in a rural setting that may, and being cared for by providers who may not know the nuances and importance of screening. We, again, fully recognize that technology may be one way in which we can overcome some of these limitations, democratize survivorship care. And we partnered with our colleagues at Caltech to develop a handheld device that can be delivered to patients at less than $100 that they can actually take with them and in real time monitor their cardiac function. You take the device, you put it on your carotid pulse, and through that carotid pulse wave, you can actually get the information directly Bluetooth to your iPhone. And from your iPhone at the core lab, we can get a measurement of someone's cardiac function. And that allows me to monitor patients in Indiana, California, wherever they may be in real time and make the appropriate referrals instead of waiting for every 2 years or 5-year echocardiogram screenings that need to happen. We tested this device around against more advanced measures of looking at heart function, including the standard 2D echocardiogram as well as cardiac MRI, and this device held up just fine. So where are we going from here? We have full, as you can probably tell, we have fully embraced the integration of technology and mobile devices into survivorship care to optimize the health of our patients. But the reality is that we're not the only ones who are doing this. This is standard of care, and it's emerging as a way in which we can actually mitigate the disparities in care in the general population. There are a number of investigators that are looking at sensor-based technologies to get real-time feedback in patients. And this is in the general population, real-time information about someone's blood pressure using wearable sensors or monitoring their blood sugars before meals and after meals and without having to poke themselves. And so this technology is emerging, will definitely be in the forefront in the near future. And for us as survivorship clinicians, it is incumbent upon us to absorb this into our survivorship planning that we're doing in our discussions. So I hope I was able to articulate some of the key points here, which are that we know that we are going to have a growing number of survivors. Many of these survivors are going to do well, but there are a subset of them that will have high risk of cardiovascular disease, especially as they age. As we're thinking about treatment planning, our best interventions are before you even give the cardiotoxic therapies, consideration of alternatives if there are. But if there aren't alternative treatments and someone needs the treatment, the cardiotoxic therapy, potentially cardiotoxic therapies, then early screening and intervention, proactive management of cardiovascular risk factors integral. And that can only be done through multidisciplinary, multi-institutional collaborations. And in consideration of a highly mobile survivor population that we know we can't expect for them to return to the survivorship clinic year after year. And that many of them have transitioned their care and that really have fully embraced the advances in technology and the day-to-day management of their life. And so with that, I want to thank you for your time and attention, and we'll take it back to the studio.
Thank you, Dr. Armenian, for that wonderful overview of the current treatment landscape and future approaches. That now brings us into our second opportunity to hear from our pediatric cancer survivors and their family members and caregivers as we build on this morning's discussion and now seek to understand patients' experiences and preferences on current approaches to treatment, as well as your preferences about future treatments for these cardiac late effects. I'd like to bring up our afternoon discussion questions, which will help give us all a sense of what we're hoping to learn from all of you and explore through discussion. So this afternoon, we're going to be asking about what you are currently doing to help treat your cardiac late effects or perhaps prevent them in the first place. And when we talk about treatments in this and all of our questions, we're really casting a wide net in what we're considering a treatment approach. We do consider drug treatments for any of the cardiac impacts and symptoms, as well as surgical procedures and even heart transplant, as we heard a little bit about this morning, to be treatments. But we also mean other things, some that Dr. Armenian had been discussing, things that maybe are not direct medical treatments, maybe more holistic interventions, maybe lifestyle modifications, anything from diet, exercise, or even just kind of modifying daily life. Anything that might make living with and navigating the cardiac late effects a little bit easier. We want to hear about that whole kind of armamentarium of what you have available to you and are using and trying. So in addition to hearing about what you're currently doing, we want to know about whether you've been told or considered clinical trials that might help with your cardiac issues. And if so, how would you describe your decision of whether or not to participate? We know where in these situations where we don't have lots of treatments to fully address these condition, that clinical trials and participation in trials is a really important aspect of your treatment plan. So we want to hear about those clinical trial experiences. We want to know how well your current treatment regimen treats the most significant symptoms of your cardiac conditions. What has helped? Maybe what are you uncertain if it's helping, or maybe what hasn't helped? We want to know what are the most significant downsides to your current treatments for cardiac late effects, and how do those downsides of current treatments affect your daily life? And finally, what specific things would you look for short of a cure for the cardiac late effects in an ideal future treatment? So keep all of these questions in mind. Think about your personal experiences that you would like to share. But to get us started on discussing these issues, we have another panel of your peers. We have Megan, Mariah, Greg, Hannah, and Marta that will be speaking to these issues. Megan, take it away.
Howdy, my name is Megan. I'm 38 years old and I live north of Houston, Texas with my husband and 2 cats. I was diagnosed with Hodgkin's disease lymphoma just after turning 14 and underwent chemotherapy, radiation, and an autologous bone marrow procedure, during which I started high school bald, so huge blow to my social life. At 32, I developed symptoms of a heart attack. Women's symptoms differ from men's, and was found to have a 99% blockage of my left anterior descending artery. The cardiologist doing the angiogram cried out, "This can't be real," and left the procedure room without telling me anything. He told my family that they only found this sort of thing on dead patients. I needed a full open heart bypass and graft for the artery, which my surgeon theorized was caused by radiation treatment to the mantle, 32 grays worth, though could also have been worsened by the doxorubicin. Before that point, I was taking a low-dose aspirin, niacin, and fish oil as recommended by my GP, as well as a cholesterol-lowering medication. My long-term team kept tabs on my heart with an annual EKG and echo scan, and I always tested just under a normal ejection fraction rate at about 55-60%. They pushed losing weight, regular exercise, and healthy food options as the best prevention of further problems. The same thing you hear from every doctor, but it's different for cancer survivors. After my heart surgery, I suffered from systolic congestive heart failure with my ejection fraction rate down to 30-35%, which required several medications to improve my heart function: Cozar, generic losartan, Toprol, generic metoprolol, and aldactone, generic spironolactone. Once my dire symptoms improved, we adjusted medications to keep my blood pressure down, then later to try to lower my tachycardic pulse. To make sure I wasn't retaining fluid, we tried hydrochlorothiazide, but it wasn't strong enough, so we moved to Lasix, generic furosemide. About a year after my surgery, I realized that I was devastatingly depressed. After all that I have gone through and continue to go through, I started thinking it would be easier to throw myself in front of a train. I started seeing a psychiatrist, getting treatment for my major depressive disorder and unrealized long-term general anxiety disorder, and I started talk therapy. My mental health has become as important as my physical health to me. They are unavoidably linked. With my therapist, I work on releasing my stress, meditation, mindfulness, deep breathing, and practicing gratitude. These help to reduce the strain on my heart and pull my pulse down. Speaking of stress, I can't hold a part-time job, let alone a full-time one. I somewhat jokingly tell people that my health is my full-time job. I check my blood pressure and pulse 3 times a day. I make sure that I have a bathroom available for about 4 hours after taking my fluid pill in the morning because I'll need to go at least every hour. I break the house cleaning schedule into a little bit every day to try to keep it clean. I physically can't do it all at once. My parents and I swap notes on meds and surgeries because they are going through a lot of what I am as they climb towards 70. I feel like I'm older than they are, and they probably worry about outliving me. Recently, I was having concerning symptoms that I thought it wise to see the cardiologist again. My EKG and echo were as expected, but my nuclear stress test came back abnormal. An angiogram found that one of the 2 grafts I had 5 years ago had occluded. So now we're treating symptoms with ranolazine, along with working to lose weight, increase exercise, and eat healthier. Even though there are precautions put into place for cancer treatment, they're not enough to keep from long-term effects harming the patient. Even though my radiation treatment had a thyroid guard, I developed nodules and had half of my thyroid removed. Treatments for cancer were not precise enough to kill off the bad cells and leave my good ones alone. I believe that medical nanobots or some other pinpoint treatment would be the best approach to eliminating the cancer cells, especially in the case of blood cancers, or possibly some sort of hemodialysis where cancer cells are filtered out. Of course, there are always hazards in any medical treatment or procedure, so the benefits would need to outweigh the risks. I hope these types of solutions will be life-thriving and not just life-saving.
Hello, my name is Mariah. I am 43 and I live in Wisconsin with my husband Troy and our Siamese cat Isaac. In 1980, at the age of 1, I was diagnosed with neuroblastoma, a type of childhood cancer consisting of a solid tumor. My tumor grew out of several levels of my spine, wrapped around part of my heart, pushed against my trachea and lungs, and took up almost the entire right side of my chest. I had multiple surgeries, radiation treatments, and 2 years of a chemotherapy clinical trial that included adriamycin, which is an anthracycline. Outdated therapeutics and the location of my tumor left me with around 100 different complex medical conditions and late effects. I also have a higher risk of developing 9 different types of secondary cancers, and I have had 48 surgeries, with most related to my cancer or late effects. Being an older, long-term survivor, I have learned about my late effects as I have experienced them. Even when information became available, it was not really shared with us. I learned the most about my cancer and potential late effects through my own research, and when I attended a 2.5-hour appointment about 5 years ago with a radiation oncologist who took the time to study my case, talk to my husband and I, and answer our questions. Shortly after treatments were finished, my parents were informed that I could experience potential cardiac issues due to the adriamycin. This was only one of the very few late effects we knew about. We later found out that part of my heart was in the radiation field, and that could cause cardiac late effects too. Thus, I had the double whammy of chest radiation and receiving an anthracycline. But I have always had a cardiologist and regular cardiac testing, such as EKGs and echocardiograms. Aside from regular cardiac testing, my parents were also told that when I was fairly young that it would not be the best idea for me to get pregnant, since pregnancy and childbirth are incredibly taxing activities on the heart, and the adriamycin could weaken the heart even without previous symptoms. My treatments may have left me infertile and unable to get pregnant anyway, but a high-risk OBGYN also told us that I should never, under any circumstances, get pregnant due to some of my current severe late effects, because there would only be about a 2% chance the baby and I would survive. There are a number of reasons why I should not get pregnant, including concerns for my heart, but not being able to have a child has been the most difficult late effect for me. Other prevention methods that I have incorporated to address potential cardiac issues are dietary changes and trying to eat healthier. Due to several GI issues and gastroparesis, my body cannot process certain foods, and I am limiting red meat for fish and chicken. In addition, I am trying to eat healthier overall and practice portion control. Furthermore, I am and always have been a non-smoker, which is a huge benefit for heart health. I know that exercising is also extremely important for heart health, but this is very difficult for me to do. I use a cane for walking and a wheelchair for longer distances because I have chronic, excruciating bone, muscle, and nerve pain in my back, neck, and cancer scar, as well as right leg weakness and numbness, so it is very difficult for me to exercise. When I am able, I ride a recumbent bike and do physical therapy exercises, but I worry about it being enough for my heart. Due to my cancer treatments, I am at risk for cardiomyopathy, heart failure, heart valve issues, coronary artery disease, abnormal heart rhythms, and others. It would be wonderful to see a medication developed to delay the progression of cardiac late effects in childhood cancer survivors. The combination of this medication and routine diagnostics and monitoring would be valuable for me and many others to help find and address cardiac late effects as soon as possible. Given the prominence and importance of the heart operating properly, as well as my risk and the fact that my potential cardiac late effects are extremely critical health conditions, I would participate in a clinical trial for a medication that could delay the progression of cardiac late effects. A clinical trial is what ultimately saved my life when I had cancer, and I strongly believe in the importance and promise of them. I also know it is important to have a variety of data, and I represent the older population of survivors. Overall, survivorship has been a difficult, frustrating, lonely journey for me, and since childhood, I have wanted to be studied to help improve the outcomes for younger and future survivors. Furthermore, I have been dealing with a substantial number of late effects, with little to no control over the number and severity of them. Simply having access to this medication would be an incredibly powerful way for me to take control and fight back against potential cardiac late effects that could easily claim my life. Thank you.
Hi, my name is Greg. I'm an associate professor of pediatrics and physician scientist at Greehey Children's Cancer Research Institute in San Antonio, Texas. My professional efforts and career are focused on improving the quality of life for the growing population of childhood cancer survivors and to use laboratory investigation to better understand how our successful treatment regimens damage the cardiovascular system. But I'm not speaking on this subject today as a physician or lab researcher. I'm here today as a patient. In 1989, at the age of 16, I was diagnosed with Hodgkin's disease. This was a major life-changing event for me and one that changed my life trajectory in so many significant ways, some bad and some good. Looking back over the past 30 plus years as a survivor, I can tell you I've been tremendously blessed by my experiences as a cancer patient and survivor, and that the benefits of these experiences has far outweighed the obstacles and daily struggles. I was treated in an era when higher doses of anthracycline chemotherapies and extensive radiation were used to successfully cure Hodgkin's disease in over 90% of patients. Going through the year and a half of these treatments was physically and mentally challenging. When I completed the therapy, I was told everything was over and I could go on with my life. What I endured the next 30 years was unexpected, frustrating, physically challenging, and scary, but it made me who I am today. My life as a pediatric cancer survivor has closely paralleled many of the key findings that have been published over the years that have detailed the extensive health complications survivors face, and many of these have been cardiovascular. As I pursued my MD PhD degrees, pediatrics residency, hematology oncology fellowship, established an early academic career, and my wife and I raised 2 sets of twins, I've also had to overcome numerous health obstacles. These have been a constant reminder that our work as pediatric oncologists and researchers is not even close to a point where we can declare victory over childhood cancer. At age 35, during my first year of pediatric hematology oncology fellowship, I underwent open heart surgery to replace a badly damaged aortic valve and to bypass 3 coronary arteries that were 95% blocked. A few years later, I had a stroke and was unable to move the left side of my body for about 35 minutes. Fortunately, my symptoms were resolved without intervention, and I was left with no permanent damage. Today, I continue with close care by cardiology, as I've subsequently developed congestive heart failure requiring close medical management, and an additional heart valve that at some point will also need to be replaced. To me, cardiovascular complications of successful childhood cancer therapy are all too real. On a daily basis, I am reminded of my cardiac limitations, and I've had to modify my lifestyle accordingly. I take 21 pills a day, including medications for diabetes and heart failure. I limit my exercise to walking and avoid walking upstairs or hills. I limit yard work and other strenuous activities. The activities I participate in with my family are often affected by my limitations. All of this can be frustrating, but when I begin to feel sorry about my situation, I remind myself of the many kids and families I've known over the last 30 years that have suffered a far worse outcome. I wanted to end my time by highlighting the hope I have for future pediatric oncology patients. We have made tremendous progress in lessening cardiovascular complications through strategies such as decreasing drug doses and better targeting radiation. More importantly, I believe we have the scientific and clinical expertise to completely avoid this outcome. But we must make eliminating cardiovascular toxicity a central goal of oncology efforts in the coming decades. We need to develop new ways of protecting the heart during exposure to cardiotoxic treatments, more selectively deliver drugs to tumors, and develop the clinical infrastructure to closely monitor the health of all survivors. I would consider anything less a failure. I strongly believe that a day when pediatric cancer patients can survive with normal cardiac health is within reach.
Hi all, my name is Hannah. I'm a 32-year-old osteosarcoma survivor from Southern California. I was diagnosed when I was 20 years old. Hearing that you have cancer when your life is supposed to just be starting really threw a wrench into all that I had planned. I had dreams and aspirations of becoming a physical therapist. I was living at a state and finding my own independence and personal identity. Little did I know my world was going to drastically change forever. I managed to make it through my diagnosis, 11 months of chemotherapy, and a few major surgeries to remove my tumor and reconstruct my right leg. When I completed treatment in June of 2011, I was naive and thought, well, that's done. It's time to move on and make something of my life. Fast forward to 2015, I was sitting in my pharmacology class in nursing school. It was the week of our chemotherapeutics lecture. I remember sitting there, half feeling really fascinated by the topic because I aspired to be an oncology nurse, half zoning out because I was familiar with a lot of the drugs and side effects being discussed. Then the slide came up with the title, Long-Term Side Effects. About halfway down, a bullet point read, doxorubicin, cardiac dysfunction, often seen approximately 5 years after completion of treatment. I'll never forget turning to my friend sitting next to me and jokingly whispered, well, guess I'll have cardiac issues next year. In 2016, approximately 5 years after completing treatment, I joined my hospital's childhood, adolescent, and young adult survivorship program. I was asked to participate in a study that was looking at cardiac late effects. I accepted, remembering that slide from my pharmacology lecture. After a day's worth of signing consents, labs, and scans, I was well on my way to joining my first study. About a week later, I received a call from my doctor who runs the survivorship program. He explained to me that the baseline data they had gathered for the study showed my heart function to be too low, and that I would need actual treatment. I could not risk falling into the placebo group of the study. My echo showed my left ventricular ejection fraction to be 42%. I've been mildly symptomatic with my cardiomyopathy. I will intermittently have episodes of heart palpitations and some shortness of breath here and there. I recall going to my first cardiology appointment, walking into the waiting room, and realizing I was the youngest person by at least 30 years. In meeting with the cardiologist, I was prescribed 3.125 milligrams of carvedilol to be taken daily and sent away, only advised to return in 6 months. I took the carvedilol as prescribed and suffered through the side effects due to having low baseline blood pressures. I found myself fatigued, dizzy, and lightheaded. I'll never forget having to run out of a patient's room during my nursing clinicals because I was starting to see stars. I ran to the nutrition room to shovel saltine crackers into my mouth, hoping it would increase my blood pressure. One of my fellow classmates came and took my blood pressure for me. It read 76/5. No wonder I was feeling so terrible. I continued this trajectory for the full 6 months. I returned to the cardiologist for follow-up, told him about my concerns with the medication and how bad it was making me feel. He told me to just make sure I stay hydrated, always keep salty snacks with me, and to continue the medication. I blindly complied, not knowing there were any other options, and suffered for an additional 6 months. It was at that time that I finally reached out to my survivorship doctor, who referred me to another physician at a different facility. This cardiologist showed me a sense of urgency. He wanted to do serial echocardiograms every 3 months, change my medication to an extended release beta blocker in hopes of not having the drastic blood pressure drops, and potentially add in an ACE inhibitor if there wasn't any improvement on the echoes. Over the next few visits, we played around with the dosing, added in the ACE inhibitor, and continued to monitor. My ejection fraction improved to approximately 45% and has maintained ever since. The question remains that had the first cardiologist treated me more aggressively, would I have been able to save some of my heart function? Another concern that was brought up during my initial appointment with the new cardiologist was whether or not I would be able to carry out my own pregnancy due to cardiac risk. My husband and I were left to grapple with how to start our own family safely. Had there been treatments available to preserve my heart function during or even after I completed my cancer treatment, I may not have even been faced with these questions. There would have been less risk to this life-altering decision to fulfill my dreams of having a family. Cancer survivors like myself deserve to live long, fulfilling lives. There is a desperate need for preventative treatment, as well as treatment and guidelines to address cardiac effects after surviving cancer. As a childhood cancer survivor, I've had to manage the effects and lifelong ramifications of my treatment.
My name is Marta, and I welcome the opportunity to share my daughter's story. In December of 2003, Sophia was 4 when she was hospitalized after several days of a painful enlarged lymph node in her left groin, constant fever, fatigue, etc., and 2 antibiotics. That night in the ICU, I saw Sophia's white blood cell count and asked an intern if they thought it was cancer. Her response was that sometimes knowing a little was worse than knowing anything at all. As it turned out, Sophia did have cancer, but we needed to biopsy the lymph node to determine the exact type. But frankly, our biggest concern at that time was that Sophia was struggling to breathe and the physicians couldn't figure out why, saying it was a completely separate issue from her cancer. When Sophia came out of the surgery, she was on a respirator, and in less than 24 hours, she was maxing out and needed an oscillator, so she was transported to Miami Children's. In less than 24 hours, Sophia was on ECMO, with initial biopsy results inconclusive. Eventually, Sophia was diagnosed with anaplastic large cell non-Hodgkin's lymphoma with small cell variant, and while on ECMO, was started on POG 9315. She responded very well to treatment, and within a few days, her lungs began to clear. She left the hospital after 5 weeks, and while still in shock, we thought the worst was over. However, that August, Sophia couldn't sleep, but wasn't able to verbalize exactly what she felt. She didn't look well, and because of her initial presentation, I knew her breathing wasn't right. She was seen by one of the oncologists who said because of the fever, they'd have to admit her, but she wasn't worried. But I was. Doctors didn't hear anything in her chest, but I told them to please go check that chest x-ray which had just been taken. By now, it was shift change, and a young nurse came in to do vitals, but couldn't get a pulse. She ran out of the room to get help. Finally, someone was listening to me. Sophia was taken to the pediatric intensive care unit, where we were told she was in heart failure. Sophia was stabilized without major intervention, so we, along with the PICU doctors, oncologists, and cardiologists, thought it was viral. She was transferred to the cardiac ICU for better monitoring, and there we were welcomed by the head of the unit with these words set in front of Sophia. Think you should know that Sophia will need a heart transplant, but she won't get it because she's in treatment for lymphoma, so there's not much we can do. After this experience, we sought the advice of a cardiologist at the University of Miami, who then sent a letter to the cardiologist at Children's with the recommended course of treatment new to children, but which we were more than willing to follow. This included infused immunoglobulin, heart biopsy, enalapril and ACE inhibitor, Coreg, a beta blocker, and a diuretic. Sophia's cardiology care was now in the hands of the cardiologist at the University of Miami. In December of 2004, Sophia finished her treatment and within a couple of years was weaned off all cardio meds except for the enalapril. For almost 8 years, Sophia lived a fairly normal life, but ultimately we learned the damage to her heart wasn't from the virus, but from the anthracycline adriamycin given as a part of her cancer treatment, and in the summer of 2011, Sophia's function started to go down. She was put back on the Coreg and in December a diuretic. In March of 2012, after her 13th birthday, Sophia got a cold which turned into walking pneumonia and another heart failure diagnosis. Sophia was hospitalized and within 24 hours had a stroke, which the doctor initially said was a syncope as she had just eaten. I actually had to follow him out of the room to get him to take me seriously as I knew it was a stroke. When they started the echocardiogram, the first thing I said to him as I pointed to the monitor is, "Isn't that a clot?" Sophia seemed stable, but a few days later crashed and was put on ECMO again, but because of the scarring, they had to go through her chest. Docs did all they could for a heart transplant, even putting a left ventricular assist device and then a right ventricular assist device. However, Sophia's organs started to fail, and then she got a fungal infection. On Tuesday, April 3rd, 2012, we made the decision to disconnect her and say goodbye. Sophia had just turned 13. I learned to advocate for Sophia at every turn and continue to do so today. I think it's important for oncologists and cardiologists to be better prepared to see and treat other Sophias. They need to know how to diagnose them properly, early, and provide the best treatment possible. Ultimately, what we truly need are effective, less toxic childhood cancer treatments that don't include anthracyclines. And if a cardioprotective agent had been available in 2003, Sophia could be alive today with or without less severe cardiac issues. Either way, she would have had a better chance for a longer, more productive life.
Wow, thank you, Marta, for sharing Sophia's story with us all. And contributing to this discussion to help us understand, the available treatments that we have and the need that we have for future treatments. And thank you really to all of our panelists for sharing. If you have treatment experiences that you would like to share, we're now at the part of the program where we're again broadening the audience discussion to allow all of you who are live here with us today, our pediatric cancer survivors and caregivers and family members, to chime in and add your experiences and perspectives. As a reminder, you can do that in one of two ways. The first way is we would encourage you to call in. You can dial in at any point this afternoon at 1-703-844-3231. Again, that phone number is 1-703-844-3231. You can call, we'll get you in the queue and bring you into the discussion so we can understand some of your treatment experiences. The other way to participate is you can see under the live stream there is a little comment box. You can type in comments with your experiences, and we'll be reading and sharing those throughout the program as well. But to get us kind of all thinking about these issues and to understand the experiences of those in our audience, we're going to start with some polling questions, just like we have gone and used some of these polling questions earlier today. So please go ahead and pull out your phones, open up that browser, open up that new tab in your web browser, go to www.pollev.com/childhood cancer. Again, that's www.pollev.com/childhood cancer. Just keep this up throughout the afternoon session, and as we go to different polling questions throughout the afternoon, the page will automatically refresh. These questions are for our survivors and their caregivers to help answer. So our first question for the afternoon is we want to get a sense and ask what medications or other medical treatments are you or your affected family member currently using to help treat or prevent the cardiac late effects or their impacts, and you can select all that apply. The options are A, blood pressure medications, B, cholesterol medications, C, valve replacement, D, heart transplant, E, medication for anxiety or depression, or F, other medications. You can select G if you're not using any medications either to treat or prevent your cardiac late effects. This polling question is limited to medical treatments. We'll have a subsequent question that is focused on other non-medical approaches to managing your cardiac late effects. One other note to make here, since this is our first question of the afternoon, where our audience can select more than one option. Just a reminder, the percentages you're seeing are not the percentages of people who picked a certain option. It's the percentage of total responses. So the best way to think about this is just look at those bars and kind of view them as a kind of like a relative ranking based off of the size of the bar. So while any final responses might trickle in, let's go ahead and look at our results. We can see that some of the most common medical approaches that we see are blood pressure medications and other medications. We did hear from our panels about the large numbers of medications that people take a day, so we'd be interested to hear about what those are and your experiences with them. We also see as the third largest response option, medication for anxiety and depression. We heard a great deal about the emotional and psychological impacts of this condition this morning, and so we'd be interested to hear about your treatment experiences for those aspects of living with cardiac late effects. We also see experience with cholesterol medications and valve replacement, nobody reporting heart transplant, and a small proportion of responses saying that they're not currently using any medications or treatments. That's okay, we want to hear from you too. Perhaps you're using some non-medical approaches, and those are important to understand as well. And that'll take us into our next polling question. So if we can, in our second polling question, we want to know, besides those medications and medical treatments, what are you or your affected family member currently doing to help manage the cardiac late effects and its symptoms? And again, you can select all that apply. Options include A, counseling or behavioral intervention, B, exercise, C, mindfulness or yoga, D, monitoring of blood pressure, glucose, and cholesterol, even if you're not necessarily taking a medication for it. E, cannabis or CBD products. F, naturopathic or herbal products. G, other dietary supplements. H, some other non-medical treatment approach that you might be employing that's not listed here on this slide. And finally, you can select I if you're not doing anything, either medical or non-medical, to help try to manage your cardiac late effect symptoms or prevent them. So we see some final results still coming in, but it looks like our top non-medical treatment approaches include monitoring of blood pressure, glucose, and cholesterol. We also see that in terms of actual approaches, treatment approaches, we see exercise as the most common strategy, followed by counseling and behavioral intervention, as well as mindfulness and yoga. We do see that there are a range of different dietary supplements, as well as cannabis and CBD, and naturopathic and herbal products that are being used, as well as some other things. So we do want to hear about what those other things might be. And nobody's reporting that they're not doing anything, medical or non-medical, to try to help manage and live with cardiac late effects. We have one more question for you before we jump into the discussion. And so if we can go to our third polling question. Just stand by for one moment while we get that third polling question up for you. Here we want to know, what is your experience or perception of clinical trials for new drugs to treat or prevent cardiac late effects? We understand that, as I mentioned earlier, often when there's an unmet medical need, people will seek out clinical trials as a way, as part of their management strategy. And so we do want to hear about those experiences. So here we want to know, what is your experience and perception of clinical trials, specifically clinical trials for drugs for cardiac late effects. So not necessarily, or we're not talking about clinical trials for the cancer treatments themselves. So the options here are A, I'm currently participating in a trial. B, I have participated in a trial and would do so again. C, I have participated in a trial and I would not do so again. D, I have not participated in a trial, and that's because I didn't know about the opportunity. E, I have not participated in a trial, but it was because I was not eligible. F, I have not participated in a trial, although I was aware of the opportunity and was eligible. G, I would never enroll in a clinical trial. Or H, if you're unsure of you or your loved one and whether they've been in a trial for a drug to treat cardiac late effects. So there's a lot of options to read, so it looks like most of our responses are in. What we're seeing is that about half of our audience has not participated in the trial, and it's because they did not know about the opportunity. So for those of you who fit into that bucket, we'd like to know, would you have wanted, what would go into your decision making to decide about participating in your first clinical trial for a drug for cardiac late effects? We say after that there were people that didn't participate in trials, but it's because they weren't eligible, and that's about a third of our group here. And so again, we want to hear what trials maybe did you try to get into? Were they specific to cardiac late effects? Were they more general cardiac treatment trials? Would really, I think that would be valuable context for us to have. And then we see there's other experiences that include people who have participated in trials. They have but would not do so again. They would never enroll in a trial, or they're not sure. All experiences we want to hear about. We have nobody reporting that they were in a trial and would not do so again. And we have no one that reported that they've not been in a trial, although they were aware and eligible. Very interesting. So with that kind of background about our audience, and hopefully all of you now are starting to think about all these different things that maybe you've tried, to make living with cardiac late effects a little bit easier. I now like to, remind you, please, we want to hear about that. We want you to call in at 1-703-844-3231. We want you to write in, use that comment box below. But to get us started, we're going to welcome our Zoom panel, a panel of your peers who have joined us for the afternoon and will be contributing their experiences and thoughts throughout as well. I'd like to maybe start with Linda. Linda, as you're looking across those three polling questions, so we've got medical drugs and medical interventions, we've got non-medical interventions, we've got clinical trials. What maybe stands out as something that has been the most helpful or most useful? We'll definitely get to talking about some of the things that haven't worked and downsides, but maybe we can start our discussion today understanding if there has been something that has made living with symptoms easier, or maybe even helped with those health issues and symptoms.
Hi. Thank you for letting me participate. And again, my name is Linda. I'm from the Chicagoland area. I have a son who's 31, who's a leukemia survivor, diagnosed at 5, relapsed at 8, had a bone marrow transplant, ended up having a kidney transplant due to late effects, and also has cardiac late effects. That's a good question. I think the best thing that has helped my son deal with his complex late effect issues is being part of a cardio-oncology team that understands what he's going through.
Okay.
Some of his symptoms were subtle, and you now have to intertwine them with his kidney transplant, and it requires a different way of looking at things because he's so young.
Yeah, and kind of thinking about that the care that he receives, has there been certain recommendations that they've had, whether that's in terms of things that maybe he should or should not be doing as part of his daily life, even diet or exercise recommendations, or maybe even more directly medical care recommendations. I'm just curious, thinking about that, since you see the value in the setting where he's getting this care, what maybe are some of the things that, have been valuable recommendations from them?
Definitely diet modification. A lot of our survivors are at risk for metabolic disorders, even despite the best changes they make to their diet. So they require usually aggressive intervention for that. Because of what he's been through, he has to be careful on the amount of weight he lifts that could strain the heart.
Okay.
And also he's obviously complex with the kidney transplant. So even treatment for some of his cardiac late effects requires some collaboration, because you don't want to let the blood pressure go too low, because you need good perfusion of his kidney that's been donated. So these kids are complicated and they have to be looked at outside the box.
Yeah, absolutely. And would you say that, kind of following that plan has both helped with maintain a healthy blood pressure, as well as maybe help avoid any worsening or exacerbation of symptoms from the cardiac late effects? How would you kind of, maybe qualitatively describe, his outcomes from following this plan?
Definitely better lifestyle has helped. I have to also explain on a side note, I have a dual role as a mom and a survivorship coordinator. So I do have some insight that has helped tremendously for his care and to advocate for himself. And I think part of it is we're struggling with this despite the knowledge we have with his lifestyle change. And, we know transplant recipients have metabolic disorders, and despite all that, they can benefit from maybe some statins. And the guidelines right now are, a lot of physicians are hesitant to start patients under age 40. So I think, in going with this discussion is there's a lot of good things out there. There's a lot of good medication out there. It's just educating providers and just allowing them the comfort to maybe start them in our complex young population.
Yeah, well, thank you so much, Linda. I'd like to bring Anna into this conversation. Again, starting with maybe the things that have been the most useful or helpful, thinking about, that whole broad kind of class of things that we're calling treatments, shorthand. What comes to mind for you?
Thank you. I am the mother of a 32-year-old cancer survivor. She was born with a neuroblastoma that developed in utero that accounted for a third of her body weight. It was stage 4. So she received her first treatment of adriamycin when she was 7 days old. And the first cardiac problems occurred when she was 4 months old. So she's had a lifetime of managing heart failure. I think the most effective things that have helped her were good pediatric cardiology follow-up that changed when she became an adult, and we had a hard time finding adult cardiologists that were really in tune to the needs of these patients. Surgery, she had valve surgery when she was 20, and that helped quite a bit. And medication, the worst thing that has happened for her was that nobody told her not to get pregnant, and except her mother, and she did. And we have a beautiful baby girl, 3 years old, but she developed HELP disease in her pregnancy, and cardiac failure was part of that.
Right.
So, and that was attended to by medical intervention. She's now on just 2 drugs to the tune of 5 milligrams a day. So surgery and good medication and cardiologists that knew what they were doing.
Sure. It's sometimes hard to know, kind of pinpoint maybe exactly, what the benefits are. And obviously, being able to successfully, have a child is a great benefit. But in daily life, can you think of, anything that you would attribute, those treatment approaches to, having helped in terms of how maybe she feels or activities and function in daily life for her?
I think the medication has helped her, and particularly now, and the fact that she had to learned to manage this at a very early age. Exercise, and she's very cognizant of diet
Yeah.
and good health. She's also a nurse. She's a nurse practitioner, and her field is adult oncology. So that sort of helps her because she's apprised of medications that are available.
Sure. Yeah, thank you, Anna. I'll just ask our other three Zoom panelists with a little show of hands. Does anyone have a treatment success or positive treatment experience that they would like to share with the audience? All right. All right. Well, all right. Go ahead, Linda, please.
I think what I forgot to add is my son, because he followed up with cardio-onc, he was started on carvedilol before his ejection fraction went below normal. And because of that, he was able to remodel and gain some function back. And I think that's an important message to bring out there.
Yeah, no, absolutely. Thank you for adding that. I'm going to check in with Steve in terms of written comments. Are we hearing anything in terms of treatment successes or positive treatment experiences?
We heard from Sarah in Norfolk, who had a relapse in 2010 and qualified for the chlorfarabine clinical trial, and it saved her heart from further damage in preparation for a stem cell transplant. And she said, I felt like going into that transplant, I felt a little bit more whole. So nice to hear that from her.
Yeah, absolutely. So please keep any positive treatment experiences coming. We will broaden the discussion here now to not only talk about those things that you've tried that have worked, but maybe other things that you've tried that haven't been as successful, or maybe I think a lot of things will fit into this category of you're unsure of something that you've tried, whether or not it's actually helping. Kind of want to hear about those as well. Also, as part of this, we want to know what are some of the trade-offs or downsides to these different products or approaches that you're trying, whether or not they've really worked. So to get us thinking about these topics, we're going to go to a couple more polling questions. So please go ahead and pull your phone back out, go back to that web page on your computer, go to pollev.com/childhood cancer. Again, you can just keep this up all afternoon, and we'll be refreshing different questions throughout our discussion. So now, thinking about all of those different treatment approaches, we want to know how well do the current medications and those other interventions control your cardiac issues. And so the options here are A, not at all, B, very little, C, somewhat, and D, to a great extent, or E, not applicable, if you're not using currently using any medications or other interventions to control your cardiac issues, or if you are not experiencing any cardiac issues, you can select E as well. So as you're thinking about this, to build on what we were just discussing, for those of you who are saying somewhat or to a great extent, we love to hear what that somewhat has meant. So you are getting some benefit. What is that benefit? And what has that looked like and meant in your daily life? And certainly for those of you that have said to a great extent, we'd want to hear about what those treatments are that you considered helping with your cardiac issues to such a great extent. We are, though, expanding the discussion, and so those of you that selected somewhat or even not at all, we want to know, what did you try that didn't meet all of your expectations? What were your expectations? And how did these treatments fall short? And so that'll take us into our next polling question number 5. Here we actually want to know about those different drawbacks of current treatment approaches. So thinking again across all those things that are on the table that we're talking about, please pick the top 3 that you would view as the biggest drawbacks of what you're currently using or currently have available. The options are A, that they're not very effective at treating the target's symptom or health issues that they're intended to treat. B, they only treat some but not all of the symptoms and health issues that you experience. C, they have a high cost or copay or are not covered by insurance. D, there's a limited availability or accessibility of that treatment approach to you. E, the side effects of those treatments for your cardiac late effects. F, they require too much effort and or time commitment to keep up with the treatment regimen. Or G, some other drawback of your current treatment approaches for your cardiac late effects that you would consider one of the biggest drawbacks, and it's not listed on this slide. And of course, H, you can select if you're not using any treatment approaches or if you are not currently experiencing cardiac late effects. So again, think about these issues. We want to hear, about these different drawbacks, of your current treatment approaches. How do you balance this? Are these things that have made you avoid some of the current treatment approaches, or are these things that you use and you try, but it comes with these trade-offs that you're now living with in daily life? So that's all on the table for what we want to hear about this afternoon. So again, to help start our conversation on this topic of things that maybe haven't helped so much or have come with some really a treatment downside, I'd like to start with Rachel. Rachel, as you're thinking about all of what is currently available, what maybe hasn't been the best treatment experience?
Well, thank you for having me. I'm Rachel. I'm from Hattiesburg, Mississippi. My son is now 13. At 23 months, he was diagnosed with stage 4 hepatoblastoma. After 6 rounds of chemotherapy and 6 surgeries, he was clear. A year and a half or so later, during routine scans, they discovered a tumor on his left kidney. That was ultimately diagnosed as an undifferentiated renal cell carcinoma, but we really don't actually know if that is the case. It didn't seem to match with any other cancers. Yeah. And it wanted to come back multiple times. And due to the toxicity of the original therapy, we chose surgery to treat rather than kind of guessing with other drugs.
Right.
So in our situation, we have many other side effects that have been more present in our daily lives. The cardiomyopathy showed up around 8 years after the original treatment. We were able to treat it with atenolol, a fairly low dose, not too intrusive in our daily routine. And about 2 years later, we were able to stop taking it. So it did what it was supposed to do. So uniquely, we are kind of in this middle place. We're not in a survivorship team yet. I anticipate that our conversations will change as we get into that. And that's due to the fact that the secondary cancer it lasted so long, and that they didn't want to kind of dismiss us before they were sure of some things. So it's hard to answer your question directly.
Sure.
We are a hope story. I didn't want to answer that before because it was just a small story of hope. But we do treat our daily lives kind of holistically. We as parents are trying to be a good example. We're active. We are runners, we're tennis players, we just like being active. We've always eaten healthy. During the secondary cancer treatment, we did try some herbal therapies, just holistic health to build his immunity. And so our place right now is kind of the wait and see,
right.
And what we don't know yet. And so I'm learning a lot about that from these amazing parents and survivors who are speaking today.
Yeah, absolutely. Well, Rachel, one thing that you mentioned that I kind of want to follow up on a little bit was a little earlier you had mentioned, the kind of the uncertainty of kind of trialing drugs versus, a choice to, have surgery, go with surgery. Did you consider and how did you consider some of the inherent risks that come with surgery and maybe recovery from surgery relative to obviously important considerations about, kind of, the uncertainty of the drug approaches and side effects of drugs?
I mean, neither choice was a good one.
Yeah.
We were just faced with one difficult choice than the other.
Yep.
We had already seen a lot of the effects from the first cancer, including hearing loss. I mean, the fact that we had a secondary cancer,
Yeah.
some emotional, behavioral issues,
Yeah.
which we've fortunately been able to kind of deal with on the front end. So the decision to go with surgery seemed like the lesser of the evils.
Mm-hmm.
We would have been guessing. We just didn't have the right medication to try, or we weren't sure, and so we would have just been trying. And then if it worked, we also didn't know how long we would have to be on it.
I hear you.
And so it seemed like the less intrusive. And of course, we had no idea that we would then need another one and another one. And ultimately, one of his kidneys was removed.
Right.
So we were faced with difficult choices.
Absolutely.
As everybody.
Yes. Well, thank you so much, Rachel, for sharing all of that. I do see that we have a phone caller that would like to speak as a parent of a child, who's passed away from speak on this topic of treatments that were tried. That's Patty from Virginia Beach, who I'd like to welcome to the program. Patty, are you with us?
Yes, I am. Thank you so much.
Yeah, thank you.
I'm Patty. Absolutely. I was introduced already, but I'm Patty from Virginia Beach, and I am mom of a fierce fighter, Abby, who passed away at age 15 last year. And I want to share a bit about our treatment experiences, and I'm not doing this to scare the incredible people that have been speaking, but really to make those listeners there that can help start change. I'd love to make them just aware of what things are occurring, and hopefully they can discover a change. Quick recap, my daughter was diagnosed at age 4 and relapsed again at age 7 with leukemia, a specific one that's hard to treat. Her heart failure was found at age 8 while prepping for a bone marrow transplant. We were sent to cardiology, and she was immediately started on CoReg and an ACE inhibitor, like we've heard from many of these people. Over the years, she was treated with the CoReg in hopes of remodeling, and we did see positive change with it, and we were just thrilled. And as her cancer continued and she became into remission, obviously the focus shifted to other things, and the heart failure was just there. Listening today really made me think about the management of the other things that people have been bringing up, specifically the hypertension and diabetes, which she had both of, maybe could have helped better. But so many of the drugs that many people have mentioned today, she was on, but then some interact with your cancer treatments, and so it just gets tricky. Abby eventually failed all childhood interventions for heart failure and was approved for some adult medication as she then transitioned to that cardio-oncology team, which did try to help. Abby then again transitioned to IV milrinone, for which she was on in the hospital, and then we transitioned to a home IV pump 24 hours a day. But it gave her more life, and we were hoping for that remodeling and that heart strength, which unfortunately never came.
Sure.
And so then the transplant discussion came about with multiple transplant pediatric centers, and unfortunately, due to chemo side effects and cancer side effects, Abby was not eligible, and so the LVAD was her only hope and option.
Yes.
Yet no children live with an LVAD for a long period of time. It's usually a bridge to transplant. but we were hopeful that maybe she could be the one. She pulled off many miracles.
Yes.
Unfortunately, this was not it, and she died of a stroke about a month and a half after the LVAD surgery, which she never woke up from. But truly, I'm here because I want to ask those that are listening that can help. They can help. Everyone out there right now battling, protect their hearts. Everyone that is not even diagnosed yet, because someone was doing that for us, which enabled the co-regs and everything to come be a part of our kids' treatment plans. So what more can we do? So please, researchers, drug developers, anyone, we need more options for everyone here and everyone out there dealing with this. But truly, thank you so much for having me. My thoughts and prayers are with everyone on here. And for those parents, hang in there. You can do it, and I'm cheering for you.
Yeah. Well, Patty, I just want to thank you so much for calling in, after already sharing so much earlier. You started out with an apology, but I just want to say that no apologies are needed. We need to hear about the realities and of the limitations in current treatments. And, I know it's so hard to share that reality sometimes, but this meeting is all about pulling back that curtain and sharing the realities. I know we all are always, it's human nature to be hopeful and optimistic, and we should be hopeful and optimistic, but we can't get to those, new breakthroughs, those new treatments and advanced, treatments that maybe already are coming down the pipeline without really understanding the full context of what you all and your loved ones and even those who have passed away have experienced. So, your participation today, Patty, has already helped advance that goal so much, along with everybody else who has. I do want to circle back to our Zoom panel and maybe come to you, Ruth. I'm going to kind of put this out there broadly in terms of any, if there's any treatment approach, whether it's something that's helped, something that maybe hasn't, or maybe whether or not it's helped has come with a downside. Is there a really a treatment experience that you would like to share with us?
Hi, my name is Ruth. I'm 20 years old. I am a neuroblastoma survivor. I am from Hawaii. I would have to say I'm relatively new to the cardiac treatments. I only recently this year started on heart medication, but I guess this past month I recently traveled to San Francisco to get a consultation on getting a surgery for one of my biggest problems is my breathing, so I have to combat with both the heart and lung problems. So I constantly have to check my heart rate and also my oxygen concentration. And that's, I guess, been kind of a big struggle. I don't know, I guess it's just been a huge balancing act. There are things that have worked really well, which is like staying on oxygen and keeping up with my heart medications and keeping up with my doctor's appointments and having a really great team.
Yeah.
Like both Linda and Anna has said before, having a great support system is really what gets you through it. But I think really we can get something better for our youth, because really they have amazing lives that they have to live.
And Ruth, maybe for you, you said that, the care team and care that you receive, your cardiac medications, and of course, the things you're doing to help at the same time with the lung problems like the oxygen, have been helping, in terms of your daily life, have those things helped you to, be able to continue doing things that, are important to you in your daily life? Would like to maybe hear a little bit about how it kind of translates to those types of things, either in terms of how you feel, or again, maybe activities or things that you're doing, from day to day.
I guess things look a little different when I do it. Things like cooking, or even baking, or even traveling. I used to be able to do things totally independent from medicines and machinery. But right now, I have to get around with the wheelchair and oxygen tanks, which I am still able to do things. They just look entirely different than the average 20-year-old, which made a huge barrier for me to accept. It took about 2 years to actually finally put this thing on, because I gotta be honest, I was really stubborn about it, and I didn't like the looks that people would give me passively in the grocery store, or walking up to the old lady with the oxygen machine, or the old man, and being like, "Hey, we're twinsy," you know?
Absolutely.
And it sometimes feels embarrassing as a 20-year-old.
Yeah. Yeah. Well, Ruth, thank you so much for sharing both about your treatments and your daily life a bit there. It's so valuable to hear that. I want to bring Marissa into the conversation as well. Again, Marissa, on this broad topic of current treatments, whether that's been a positive experience, maybe a not so positive experience, is there something you'd like to share?
Well, thank you for welcoming me. My name is Marissa. I'm in upstate New York, and I am the mother of a survivor, even though she technically doesn't fall into that category yet. We are in a more of a situation similar to Rachel. We are barely off treatment. We're off treatment for ALL leukemia for 2 years and 2 months. And we have not run into any cardiac long-term side effects yet. We're not long-term. And the reason that I'm here is really to gather more information to prevent anything that I can prevent. Our oncology team is magnificent. They saved my child's life. But when it comes to survivorship, it's really kind of fall off a cliff. And you're not told anything about what to do or what to look for or what to expect past a certain point in treatment. And my oncologist is fantastic, but she told me once that children don't need to eat vegetables. And from her perspective, it's true, because they survive and then they move on to other teams, and that's where they are. So I feel like my mission over the past 2 years has been to dive into everything that I can find, from dietitians through LLS and through panels such as this, to see what I can do to prevent anything from happening beyond diet and exercise. And there are other challenges. Maeve is now 10 years old. She became briefly diabetic during treatment from the steroids, and she has a craving for hot dogs. So it's about balance and trying to find those pieces of diet that she can indulge in, but to provide habits and to look for things before it can happen. I'm really not a wait and see kind of person.
Right. Yeah.
And it's been a challenge. So I appreciate all of the voices and all of the stories and perspectives and all of the information.
Yeah, well, Marissa, I mean, it's an interesting kind of challenge, or that you mentioned specifically around diet and counterbalancing. I mean, I think for anyone, it's difficult, but having to fight, the hunger and urges from steroids, can't imagine. In terms of navigating maybe more of the treatments and what treatments might be able to provide some protection from progression. Is that, can you tell us a little bit about where you all are in your journey on that front, and if there's been any kind of challenges in kind of learning and navigating that?
Well, I think the biggest challenge is that the team that we see every 6 months now, they don't have anything in place for that.
Yeah.
Like, we are there to simply get a CBC and to be monitored and make sure that there's any stomach pain that she's having is, nothing is acute, but we don't look at the chronic things that could happen. So we don't have a doctor that we can consult that knows enough about progression. So everything that I've been doing and all of the experts and all of the reading that I've been managing is really on my own.
Sure.
And there isn't much representation for parents to take on that type of journey. You are on your own.
Yes.
And we really do need more representation. We need more people to be able to stay up for us and say, okay, I'm looking into it from a medical perspective.
Sure. Well, thank you so much, Marissa, for providing this perspective. When we haven't, we've mostly been hearing from people who have already experienced cardiac late effects, and so valuable to hear from someone who's, with your child navigating, prevention, of these potential late effects. So thank you so much. I do want to make sure we have time to cover some future perspectives on future treatments, but before we do that, I'm going to check in with Steve. Any other comments might have come in on current treatments?
Nothing on current treatments, but we did have a couple of comments on future treatments, which I'd love to share it when you're ready.
Okay, sounds good. All right, well then, let's go ahead and broaden this discussion one more time. This will be our last polling question for the day. So go to pollev.com/childhood cancer. If you're already there, you'll see that what we want to know here is, we've explored what it is to live with cardiac late effects. We've explored, your experiences with existing treatments, both good and bad. And so now what we want to do is understand, your priorities and preferences for, a next future treatment for you or your loved one. So the question is, what would be the most important impacts from a new treatment for you or your affected family member? And we're going to give you the option to choose up to 3 of the following potential positive impacts. Those are A, less toxic cancer treatments with reduced impact on heart health. B, protective treatments that could prevent heart effects from those cancer treatments. C, improved treatment options for symptoms of cardiac late effects. D, things that would stop further progression of the heart disease itself. E, something that would help you or your loved one recover some heart health. Or F, some other important aspect of living with cardiac late effects or the onset of cardiac late effects that you would like to see impacted from a new treatment for you or your affected family member. Again, please select up to 3. And as you're making this selection, please think about the why here. Why would you prioritize one of these things over another? I mean, we know ideally we would like a cure or an absolute protective, protection from cardiac late effects, but short of that, we very much want to hear whether it's something on this slide or maybe something unlisted, what would these impacts mean for you or your loved one? So what we're seeing from the results is that, and again, these percentages are not percentage of people, but the percentage of total responses. We're seeing that the highest selected top impact that you'd like treatments to address is something that would be protective to prevent the health effects of existing cancer treatments. After that, we see it's your next top priority would be less toxic cancer treatments to reduce the impact on heart health. And then we see, as well, top 3 selections from a good amount of people, and I'd say they're pretty close to one another, but from greatest to least in terms of responses, we see stop further progression of heart disease, improve treatment options for the symptoms of the late effects, as well as the desire to recover some heart health. And we do have some others, so we want to hear about those as well. So again, if you would like to call in and share your views on what you would like from future treatments, please call in at 1-703-844-3231, or you can also write in with those perspectives as well. But I'd like to give our Zoom panel an opportunity to weigh in, and maybe we can start. Rachel, I saw you flagging your hand there, so we'll start with you.
In regards to the other category, just being in the situation where we are, prevention is the biggest goal for us.
Yes.
And earlier they talked about genetics, and I know that not all hospitals will do the genetic testing, but it would be so amazing if that did become more common practice in our treatment of our children, so that we can measure those probabilities and then maybe create scans and tests that could predict things. I mean, obviously, predicting the future is hard, but but if we could take the information that we have, that would be really nice.
Sure. No, yeah, being able to make more informed decisions and anticipate and plan, hear that loud and clear. But I do want to maybe probe a little bit on the first part, which was, the idea of your treatment goal is prevention. What is, if you, I know this is hard, but top of mind as much as you can, what would be your measure of success for something that would be preventative? Is it, having some of these things happen later? Is it, if they do happen, they're less maybe severe? Is there a particular thing that you want to try to avoid? Because we've heard of so many different, symptoms and health effects of these cardiac late effects throughout today. So just kind of, when you said that, I'm sure there was something in mind. If you could just maybe share a little bit about what that is.
I mean, I guess everybody's ultimate goal is for it either to never happen or never happen again.
Right.
And then I guess kind of right below that, I would put having confidence in my team, knowing that if something did come up, that it could be treated, and that it wasn't a guessing game of, well, you're an anomaly or your situation is so, which we've heard today, right. That people go to their team and don't have answers. So building more confidence in the survivorship teams and even the non-survivorship teams, the current oncological teams that you're working with.
Yeah, well, thank you, Rachel. I'm going to do a quick kind of go around our panel here. So I'm going to ask each of you the same question, if you can kind of quickly share an answer. But I'm going to go to Linda next. Linda, what would be, what would you view as a future treatment goal you'd like a treatment to help be achieved? What are you looking for, kind of short of complete, avoidance or resolution of cardiac late effects, which again we all want? What would that look like in your view for your personal situation?
Obviously prevention is number one, like you said, but then the next one would be to catch these to catch changes before they become catastrophic. I think right now there are some medications out there that can do that. They're probably not well studied in our patient population. That could be part of the problem. So maybe opening up studies to this high risk population would be huge. And then kind of like off to the side is funding to better educate primary care and cardiology out there. Not everybody, as Rachel said, will have access to genetic testing. That should be the end result, right? Is like we could nail it down there. Yeah. But there's so many people who live in rural areas or don't have the availability to the technology. So you rely on primary care, even local cardiology teams, to not dismiss our patient population and also know what their risks are.
Sure. Thank you. Just going around, Ruth, what would you like to see from a potential future treatment?
I mean, yes, of course, prevention. And I think just access to all these possible solutions to these medications that might be available to or even just knowledge to patients, because a lot of people, doctors and healthcare providers, they just don't know, or the patients aren't given an answer, or and they're just left with, oh, you're kind of like a unicorn. And it's like, okay, well, that's good, but we still gotta figure this stuff out because I'm still living.
Sure. Thank you, Ruth. And Marissa?
Well, I second everything that we've been hearing. Obviously, prevention, access, and information. For our family, it really is knowledge and guidance because of the soft period that happens after treatment and before survivorship. You know, we're floating on our own. So in terms of treatment, I don't feel I can answer that question, but I certainly feel like I have a bead on the needs of our small community. Yeah. And I just want to put something out there in terms of prevention. There's not a lot of attention paid to the effect of this on the mental health of the patient and on the family, because every day we see children in clinic that are struggling and some that have passed, and it affects everyone.
Sure. And Marissa, you know, just to kind of probe, I think kind of similar to what I asked Rachel, you know, in terms of you know, prevention, you know, of course, absolute prevention is the ultimate goal. You know, is there something short of that that would be meaningful, you know, if a treatment would be able to provide it? And if so, you know, what might that look like?
I'm struggling to answer that. I think that short of that, more information about side effects of some of these drugs that we do get. Okay. And there is a place just after diagnosis when you're inpatient with your child where you are signing sheets of paper, not even being able to process side effects of some of these drugs. That obviously I couldn't say no to chemotherapy even if I wanted to. And I wouldn't, because it did trade an acute situation for a chronic one, but it saved my child.
Yes.
I think that there's not enough attention around the side effects of some of these drugs and how they can be mitigated before they're given.
Yes. Okay. And we'll give Anna on our Zoom panel here the final word. You know, so Anna, please, would love your thoughts about, you know, what you would look for, you know, short of that kind of complete cure, complete prevention from a future treatment for cardiac late effects.
Right. Everything, obviously, what has been said. But I asked my daughter and to give me an answer to this question. And she said, obviously, better drugs and accessible drugs all around, both in terms of preventing cardiac long effects and better chemotherapy drugs that don't do this. And also she said, as you know, the FDA, I think, as you all explained, it has oversight of the distribution of these drugs and how they are marketed and that sort of thing, to make sure that whoever gets them and all the subspecialties are educated, as our colleagues here have mentioned. And I would simply add not just the primary care, not just the cardiologist, but the fertility specialists and the OBGYNs.
Yeah. Well, thank you so much, Anna. And thank you to our whole Zoom panel here today for contributing throughout our discussion. We're going to go to a phone caller and some written comments, but I didn't want to leave you all without at least thanking you all personally for your contributions. But we do have Erica from Portsmouth, New Hampshire, who is a survivor and would like to weigh in on this topic of what she would want to see from future treatments. So Erica, I'd like to welcome you to the program. Are you with us?
I am. Can you hear me?
I can.
Perfect. So I am an osteosarcoma survivor. This past St. Patrick's Day marked 30 years cancer-free, 25 years cured.
Wow.
And when I was first diagnosed, and I'm sure a lot of people here can relate to this, I was told of potential side effects, cardiac, liver, hearing, etc. But the alternative was death, and so obviously we were going to treat the cancer.
Yes.
But what we don't learn early on is how to advocate for ourselves, how to ask questions back when we're asked questions, and how to really dig in deep and analyze everything that's going on. And doctors don't necessarily volunteer information. So we don't know if there are alternative treatments or if there's something that can be done to lessen the side effects, et cetera. We are on save the life mode, right? Mm-hmm. And so I think it's important that doctors really step up and focus on education and take the extra steps to make sure that their patient and families know the actual severity of potential side effects, what alternative treatments can be, and what's going to happen down the road. So here I am 30 years out, and I'm very good at advocating for myself and asking questions. And when I go to see my primary care physician, I switched to a new one this year, and I said to her, it's been a long time since somebody's taken a look at my heart, and I know that heart damage is a potential issue. And so she ordered an EKG. I followed up with a cardiologist because they didn't like what they saw, and I now have a cardiac ultrasound scheduled. But if I hadn't advocated for myself, that wouldn't happen. And I agree that it's very important that primary care physicians and cardiologists are educated on potential long-term side effects of childhood cancer treatments, because it's just simply not there. We fall through the cracks, and our symptoms are not caught until they're severe, and we have really life-altering impacts from that.
Yeah, well, thank you so much, Erica, for sharing that. And I think it's, kind of, we're hearing kind of this theme really arising in terms of, needing, more, both from the monitoring as well as the treatment perspective, more information and more proactive, and informed clinical care and decision-making. I do want to check in because I know we have gotten some written comments, and Steve, you'd mentioned on future treatments. So for those who have written in, what have we heard on this topic?
Yeah, well, first I just wanted to say in response to the last comment that we did get a very nice note from SK, who wrote that, the doctors, nurses, and other providers like me listening are absorbing all of the stories and learning important lessons. So I think that really speaks to the breadth of this meeting. Earlier, we had a chance to hear from two clinicians who are also survivors, Greg in San Antonio, who told us he had open heart surgery, and Jacob, who is a trained trained physician scientist in preventive cardiology and epidemiology. And in terms of their views on future treatments, Greg writes, I think existing clinical trials for cardiac late effects are limited, and we need more investment in research that will result in new interventions that can be tested. And I think this is also echoed by Jacob, who had a couple of comments that he hoped we'd relay to the FDA people on the call, essentially urging that there be more trials in the following three areas: primary prevention, secondary prevention, and third, tertiary prevention. So in the primary prevention area, he's advocating for designing treatments or additions to the treatment of primary childhood cancer that greatly reduce the risk of cardiac complications over the life. And I think everybody on this call would agree. On the secondary prevention side, he points out, the need for the effectiveness of more screening and how to treat asymptomatic changes found on those screenings. And then in the tertiary prevention comment, looking at how well treatments used in the general population help survivors versus our population and the specific treatments particular to our population. So I think he makes some great comments and just closes by saying, I'm concerned that trials of cardiac agents during primary cancer therapy may be showing falsely positive short-term results, but are actually not creating long-term positive changes to the heart, i.e. preventing long-term damage. So no shortage of issues there, and just appreciate what he points out, because I think it's the reason why we're all here today.
Yeah. Thank you, Steve. And this now concludes our portion of today's meeting, where we have been listening to you that are survivors of pediatric cancer, the family members, the caregivers, mostly parents of their kids who are pediatric cancer survivors. And it's really been an incredible day. As your meeting moderator, it's been, I just have to say, you all have, really done what we set out to achieve, which is to really pull back that curtain of what it is to live with these cardiac late effects, worry about them coming, onsetting, worrying about them worsening, worrying about heart attacks, sudden death, needing heart transplants. I heard so eloquently about how this is just a ticking time bomb that is hangs over your heads each and every day, and that's on top of just how hard it is to navigate the symptoms that make life so difficult, and on top of that really complex and ultimately insufficient set of current treatment approaches. So there's so much that you all are dealing with, and we needed to hear that today. And as your moderator, I feel that really has come out. So I just want to personally, as the person that's been talking with you all day, just thank you so much for each person who was so brave to chime in and share. So at this point, we're going to have a summary set of remarks. This is not intended to be a comprehensive summary. In fact, that would be impossible. Any summary done on the fly is really a difficult job, given just how much from what we've heard today. But I'd like to introduce Larry Bauer, who will be giving those summary remarks, my friend and colleague, who is really a perfect person to do this. He worked for 17 years at the National Institutes for Health, where he worked in clinical research, and I know a lot of that work was in pediatrics, and then went to the FDA and worked there as a regulatory scientist for 10 years in the rare diseases program, helping advance products in development for many different rare conditions. So without further ado, I'm going to pass it over to Larry to share some summary thoughts.
Thank you so much, James. I appreciate it.
It's been an incredible day, and I'll do my best to summarize, and if there's any points I've missed, I apologize in advance, but please know that at the end of the meeting, we're going to create a voice of the patient report that will be a more thorough document covering this meeting. So today our meeting was opened by Steve Wasala, the co-moderator. He's the CEO of Children's Cancer Cause. This was followed by a presentation from Dr. Greg Raymond from the FDA Oncology Center of Excellence and the Office of Oncologic Diseases. Dr. Raymond discussed the serious effects on quality of life in childhood cancer survivors. He emphasized how important it is to evaluate long-term safety in new cancer treatments, not only efficacy. We have to also look at these, long-term safety effects. He shared that patient-focused drug development meetings, they're valuable to the FDA to learn from people living with cardiac late effects and their care partners to help the FDA better evaluate meaningful clinical benefits in new treatments. The FDA was ready to listen and learn, and he said that you all have a lot to teach. This was followed by a great clinical overview presented by Dr. Smita Bhatia, who's a pediatric oncologist from the University of Alabama at Birmingham. A couple of her key points were that people are at risk for cardiac late effects after chemotherapy treatment, especially anthracycline therapy. They're even more at risk if they've had chest radiation, a young age at exposure, female, or if they have other cardiovascular risk effects. They develop cardiac necrosis that leads to fibrosis in the heart and scarring, which leads to dilated heart and eventually cardiomyopathy. There are certain genetic risk factors that are continued to be studied, and work is being done on developing predictive risk factors to better screen people that might be at risk for these cardiac late effects. Then in the morning, we shifted gears to listening to some patient testimonies. We heard from Susan, who's a Hodgkin's lymphoma survivor. She shared that aging as a survivor of childhood cancer is terrifying. She eventually required a heart valve transplant, and she said, the treatment that saved my life now seems to be slowly stealing it. And on difficult days, I feel as if survivorship is a progressive terminal illness. We heard from Charlene, who's mom to Ruth, who was treated for stage 4 neuroblastoma at age 5. Ruth has had a variety of cardiac late effects, including cardiomyopathy and decreased lung function, and at age 20, uses portable oxygen and already needs a wheelchair for longer trips. These cardiac issues have affected every part of her life, and she's had many challenges as she approaches adulthood. We heard this again and again, as kids are starting to grow up and become adults, the issues change. We heard from Lynn, who's mom to Peyton, who had embryonal liver sarcoma and is now 17. There was only one treatment option for her chemotherapy. Peyton now is regularly screened for cardiac late effects, and she's plagued with worry as she gets older. Her mom shared cancer is a restless and relentless disease that affects the mental and physical health of my daughter and our entire family for a lifetime. We heard from Kelsey, who's 29 years of age and had juvenile myelomonocytic leukemia at age 3. She's gradually experienced chest pain, tachycardia, hypertension. The tachycardia affects exercising, playing sports and activities. She stated that the doctors say we don't know what's wrong with you, and there is this looming dark cloud over you, that there's a possibility that things are heading for the worst, and that is the worst feeling in the world. And finally, in the morning, we heard from Patty, whose daughter Abby was age 4 and had leukemia and was treated with doxorubicin. She eventually developed serious late cardiac effects. She developed chemo-related cardiomyopathy and rapidly declined and needed home nursing care for years of her childhood. She was exhausted, slept often, had GI difficulties, pain, kidney issues, lost mobility. Abby could not do much of anything as a child of her age usually does, and she was even had to be homeschooled. Abby was eventually needed, but was not eligible for a heart transplant, and at age 15 had a left ventricular assist device implanted, but never woke up from surgery and died from a post-op stroke. Patty stated, "My daughter's life ended due to cardiac long-term effects, and she ran out of treatment options."
So during the morning, people reported key symptoms of the tachycardia or rapid heart rate, shortness of breath, fatigue, brain fog, chest pain, depression, and anxiety. Fear of the unknown was a common theme we heard all morning long, and a great concern for the future is disease progression. When is the next symptom going to happen, or when am I going to develop cardiac late effects for those that haven't had any symptoms? Some people, the cardiac symptoms can increase gradually over time. Others, it's more aggressive. And most impactful symptoms that people reported were shortness of breath, fatigue, and the depression and anxiety, which impacts all activities of daily living. After our break, we came back and shifted gears to talk about treatments. The afternoon began with a presentation by Dr. Saro Armenian from the City of Hope Comprehensive Cancer Center. He talked about emerging cellular therapies, such as CAR-T therapies that impact the cytokine storm that sometimes is seen in cancer therapy. He talked about how cancer treatment accelerates just normal cardiovascular deterioration that we all experience as we age. He said there's emerging technology-enabled cardiac monitoring, and he emphasized the importance of early and ongoing cardiac screening. This came up again and again. He emphasized the importance of ongoing long-term vigilance and surveillance in childhood cancer survivors. He said aggressive management also of the risk factors is key to postponing consequences. And a multidisciplinary approach is needed for successful screening and treatment. Then we heard from another panel of patients and caregivers talking about treatments. First, we heard from Megan, who's 38 and was treated for Hodgkin's lymphoma. At age 32, Megan developed symptoms of a heart attack and had 99% blockage of her left anterior descending artery and needed open heart surgery for a bypass graft. She uses Cozar, Toprol, Aldactone, and Ranolazine for cardiac symptoms. She also uses exercise and dietary changes to try to manage her disease, and she hopes that new treatments will be life-thriving and not just life-saving. We heard from Mariah, who's 43 and had neuroblastoma treatment at age 1. She tries to exercise and control dietary intake, but uses a cane for walking and a wheelchair for long distances. So adequately exercising is challenging for her. She stated, I'd participate in a clinical trial for a medication that could delay the progression of cardiac late effects. A clinical trial is what ultimately saved my life when I had cancer, so I strongly believe in the importance and promise of them. We heard from Greg, who's an oncologist himself. He had treatment at age 16 for non-Hodgkin's lymphoma. At age 35, he had open heart surgery for valve replacement and bypass surgery. This was followed by a stroke, which did resolve well. He's modified his lifestyle, but he still has to take 21 pills a day, including for treatment of diabetes. And for the future, he hopes that we can eliminate cardiovascular toxicities and develop better monitoring systems post-treatment. 2 key factors for this meeting. We heard from Hannah, who's 32 and was treated for osteosarcoma at age 20. Her cardiac effects were treated with carvedilol, but experienced hypotension and feeling dizzy and lightheaded as side effects. She then added an ACE inhibitor. She stated, why are we only treating the patient once cardiac compromise has already occurred? Cancer survivors like myself deserve to live long, fulfilling lives. And finally, in the afternoon, we heard from Marta, whose daughter Sophia was 4 when she was treated for anaplastic large cell non-Hodgkin's lymphoma. Sophia developed heart failure and tried a combination of immunoglobulins and several cardiac drugs, which were effective and helped her for about 8 years. But at age 13, she developed pneumonia, which led to heart failure, which led to a blood clot, and she was put on ECMO treatment, but she ended up developing organ failure and eventually was taken off life support and died. Her mom stated, ultimately, what we truly need are effective, less toxic childhood cancer treatments that don't include anthracyclines. But until then, we must take a team approach to obtain better outcomes. So we heard in the afternoon about the tremendous unmet medical need in the cardiac late effects community. Treatments mostly only help somewhat, and some interventions are severe, such as heart transplant and other cardiac surgeries. Treatments can be helpful, but most do not really treat the underlying cause or stop progression of cardiac late effects. Treatment's complicated, especially due to comorbidities and other conditions that overlap with the cardiac conditions. So we need cardio-sparing chemotherapy. We need research and development in this area to help these people. So thank you. And now to close the meeting, I'd like to turn it back over to Steve Wasala in the studio.
Thanks, Larry. That was a terrific summary. And it's really been an incredible day of sharing personal insights that are really helping us all better understand the impact of cardiac late effects on survivors of pediatric cancer throughout their lifetime. Thanks to the FDA for giving us permission to hold this meeting, and to all the FDA staff who tuned in today. Special thanks go to Shannon Sparkland from the FDA's patient-focused drug development staff, who really guided us through this process the past year. And thank you to Dr. Riemann from the FDA for your perspectives on the importance of externally led patient-focused drug development meetings, and to Dr. Smita Bhatia for the very interesting clinical overview, and to Dr. Armenian for his perspective on current and future treatment options and approaches to prevent cardiac late effects. And thanks to the Dudley Digital Works media team for all of their work in putting together this great webcast, and to my partner James Valentine, Larry Bauer, and to the Children's Cancer Cause leadership team of Jess Keene, Charles C. Stubble, and especially Julie Taylor, who worked so hard to plan this meeting. And I'd like to thank our supporters, Day One Pharmaceuticals, Whole Foods, Community Health Charities, and the Stewart Initiative for Cancer Survivors. And to our partner organization, the American Academy of Pediatrics, the American Society of Clinical Oncologists, the American Society of Pediatric Hematology Oncology, Teen Cancer America, and the Andrew McDonough B Positive Foundation. This meeting would not have happened without you. But a huge thanks goes to you, all the survivors, caregivers, and family members who shared your experiences. And to all of those of you who called in or wrote in giving your insights, this meeting couldn't achieve its goals if it weren't for you. I'm pleased to let you know that today's topic will be highlighted next month at another meeting, which will be the first International Pediatric Cardio-Oncology Conference scheduled for October 21st to 22nd in Cincinnati. It's being sponsored by Sophia's Hope, who we heard from Marta earlier, Cincinnati's Children's Hospital, the University at Buffalo Jacobs School of Medicine, and the Biomedical Sciences Department of Pediatrics. This meeting will bring together thought leaders, practitioners, and advocates in the field of pediatric cardio-oncology for a uniquely focused session. What's next for us at Children's Cancer Cause? As Larry and James have alluded, we'll compile all of the information from today into a Voice of the Patient report, which will be available on our website in the coming months, along with a recording and a transcript of the full meeting. The web link to submit comments for the report is open for another 30 days, so please consider submitting additional comments, which will be included in the report that's written up. The video will be on demand immediately after today's meeting at the same link you are on now, and the follow-on report will be publicly available to anyone once it's published and posted on our website later this year, early next year at childrenscancercause.org. And there will also be a link there for the FDA website. In closing, I just wanted to extend our deepest thanks to all of you who tuned in today. The impact of this meeting and your collective voice will be felt for years to come, so thank you.